Else is here, and we are quorate. Any declarations of interest not yet made relevant to the agenda? No, it's okay. Right, just going to chair's announcements. You'd expect me to make a comment, and I want to make a comment on the recent events this week that happened just up the road. And all I'll say is this, and it's a pity having to say this again, but I want to say it, which is an immense thank you to all our NHS and emergency service staff who once again performed brilliantly both during the incident and to support those people who've been tragically injured. So thank you very much to all those staff. There's a couple of other things. I am not going to embarrass him in any shape or form, but this is the last meeting of Graham Irwin and when our Chief Exec. We will be thanking Graham in the usual way in due course. And that's all he wants me to say at this meeting. But it's also the last meeting of Steve. Steve Borden, where are you, Steve? There you are. Apologies. Steve has announced his retirement in the summer. Steve, I am going to say thank you very much for your contribution. Sometimes with a mischievous look in your eye, you make comments, but those comments are always really valuable and cause us to think as well as contribute and add to the agenda. Thank you very much for that. Okay, I think we're going to go straight into the experience and achievement story. Is that lined up? Yep.
To make a real difference in people's lives, we need to join forces and work together as one big team. In Cheshire and Merseyside, we have a great history of doing that already. We're a marmot region and we work together to tackle health inequalities. And now we have our Health and Care Partnership Plan, which we call All Together Fairer, to reflect our marmot work. The plan is our roadmap to improve people's health at every stage of their lives, and it sets out our mission to work together to eradicate child and family poverty.
An independent report has found over 100,000 children in our sub-region are currently living in poverty. And the scale of inequality is staggering and will have a direct impact on the health of these children, as well as on future generations. That's why we've released a joint statement with our partners across the system and called for an end to this. Because we want to see no child in Cheshire and Merseyside living in poverty. And fighting inequalities will certainly help with this. One example being our work around healthy advertising.
Advertising for unhealthy and processed food and drinks on billboards is driving up our obesity rates, especially among our children. There are enough of these adverts out there without them being on sites owned by local councils, which is why, starting in Knowsley, we changed the rules to ban unhealthy adverts on any spaces we are in charge of. And thanks to All Together Fairer, other councils in the area are doing the same. It's just another example of how we're looking at the wider elements that impact our health, like our work on smoke-free sites.
We're bringing the ethos of prevention into the NHS, thanks to the NHS Prevention Pledge. Our goal is that every hospital in the area has a firm policy on being a smoke-free site. This will help us to encourage our patients not to smoke in or around the hospital and consider vaping instead, so they can quit for good. This collaborative effort can make a real difference, much like our collective mission in Cheshire and Merseyside to tackle racism and discrimination, which we know will change so many lives for the better.
We know that discrimination due to a person's ethnicity can have a serious, long-lasting impact on their health and well-being. For example, black women in England are up to 6 times more likely to experience serious birth complications during delivery compared with their white counterparts. Tackling racism, discrimination and their outcomes is one of the 8 marmot principles that guides all of our work. And as a system, we are committed to creating greater fairness and equity for our ethnic minority communities. Whilst this is considered a social determinant of health, we are clear that tackling discrimination and being anti-racist should be present across all of our work and not just limited to one section or a specific programme. This approach will create the most positive impact for our residents, much like the work in our second pillar, the Supporting Healthy Behaviours programme, and All Together Smoke Free. Thank you. So people, I'm sure, will recognise that in that video, apart from the last bit, which was really well presented, partners from right across our system working together, to get towards the social determinants and prevention. It's fantastic work, and we feel really I feel really uplifted when we're in that work, because we can see a stronger future for the people that we serve. Any comments? We'd be happy to move on. Yeah, thank you. So, Graham, I think we're over to you.
Chair, thank you. I want to first of all say there is a specific recommendation within this report around the ICB scheme of delegation. With your permission, Chair, I want to withdraw that item today because certain representations have been made to both myself and yourself that would suggest this needs a lot more debate that we can't do justice to within this meeting. Secondly, I want to thank my team who helped put this report together. You've already acknowledged that I've said this is my last meeting and I don't want any form of fuss, but my team in putting this report together have tried to highlight a number of successes since the inception of the ICB. And one of the things that you know, Chair, because we debate this often, is we kind of concentrate on a kind of deficit model. So no matter what we've achieved, no matter what we've done, actually all of our attention goes to there is much more to do. And so I am going to talk about two particular things today that fall in there is much more to do. So firstly, I highlight within the report some issues around the financial regime that we exist within. Some people will have seen this played out in public fora as well as through the papers of our board, but we were one of the last two ICBs in the country to agree a financial plan with NHS England this year. You know from the papers that plan includes £178 million worth of deficit support funding. So if we deliver that plan this year, NHS Cheshire and Merseyside will be spending about 2% more than its legitimate allocated resources from NHS England. Now, because of component parts in that plan, and I'm sure partly because of the lateness of our ability to agree that plan with NHS England, there are concerns and risks. Some of those concerns and risks are risks that we would self-declare, that we were clearly cognizant of, mindful of, and thinking about how we addressed. And that is one of the reasons why the board asked me to bring in and appoint Mandy on a basis to tackle some of the financial turnaround and system turnaround issues that we have. But to gain more confidence on this, NHS England have asked that we accept a piece of diagnostic work by PricewaterhouseCoopers that will take place over the next 2 or 3 weeks. Now, I want to frame that slightly further, but that diagnostic work by PricewaterhouseCoopers is to gain confidence on the deliverability of the 25-26 plans. But I want to frame this further in that we have two challenges. We have a challenge that is a here and now challenge, and most of that challenge resides or is mapped to deficits that exist within the providers of care within the system. So that 178 million deficit is made up by the ICB delivering a surplus and collective providers across the patch delivering to a 228 million deficit plan. This diagnostic work will attempt to give us a real indication of the deliverability of that, the confidence, and whether more action is required. But we have a second problem that I want to highlight to the board, and it's a problem that the board kind of knows about and has been cited on, and it is something that the non-executive directors asked us about frequently, and that's our longer term plan. And so not only are we receiving deficit support above our allocation this year, but NHS England have indicated their desire to accelerate a movement towards the fair share use of funding in the country. Now, there has always been a calculation of fair shares funding for the NHS that uses a publicly identifiable formula, but the NHS moved away from its historic funding regimes during COVID and is only on a slow journey to move back to that regime. And so the fact that we are spending more than what would be considered to be our fair share allocation, and all of the indications is that NHS England are going to use their powers to speed up a move back to fair shares, then we also have to consider the fact that we are effectively over-commissioning healthcare, and we need to develop a long-term plan that will reduce us back to our fair shares of that allocation. Now, the powers that NHS England have used this year and have used for the first time is when they publish their growth in ICB and other budgets, they cut our growth by 0.5% this year. And they cut our growth by 0.5% because that means all of those ICBs that have more than their fair target share, they will get slightly less growth, and it will therefore over a period of time even out. I believe that next year they will cut that growth by a bigger percentage, and then the thing that we must examine as a board is the more quickly we can get back to fair shares, the more unfettered our ability to make decisions will be. And of course, the important thing for me here is when the 10-year plan is published, there will be lots of opportunities and ideas about how we make the 3 shifts, how we invest in care outside hospitals, how we invest in the digital agenda, how we invest in more proactive and less reactive care. Well, our ability to do that will be constrained if we do not get our underlying financial position in order. So we need to recognise those 2 big challenges, and the board needs to be aware of, one, the work we are doing immediately on a diagnostic with PwC, but then secondly the need over the next quarter to bring forward a 3-year financial strategy for the ICB. I'm going to highlight one more area to talk about today, and in my report this is referred to as the model ICB, but colleagues will know that very recently the Prime Minister made an announcement. The Prime Minister's announcement was effectively about the abolition of NHS England, with the majority of the functions of NHS England being transferred back into the direct control of the Department of Health. Through that process, they confirmed in terms of the architecture that ICBs were here to stay. It was not a layer of the system that they thought it was appropriate to remove in their campaign for running the NHS in a different way, but they did talk about redefining the role of the ICB through that process, and they also announced with that, and this was in the Prime Ministerial announcement, that ICBs in line with NHS England would need to cut their running costs by 50%. Now, that 50% cut in running costs will be a 50% cut in running costs for the average ICB. We, as an ICB, are larger in size and scale, and that brings to it certain economies, And also, over the last 2 years, we have taken the requirement to reduce our management costs seriously. So of the 42 ICBs, I think, were the 11th cheapest in terms of management and running costs across the country. And so therefore the cuts that we will be required to make are closer to 30%. Rather than 50%. So over the coming weeks and months, we will be developing proposals for the reshaping of the ICB, the focusing on those future defined functions, and a significant staff engagement process that will lead to a number of redundancies for our directly employed workforce. So a lot to do, a lot for us to be cognizant of. As I say when I talk to many of our staff in staff briefings, that there is a balance to be struck here. One of the things that we must always remind ourselves is it is an absolute privilege to work in public service. It's an absolute privilege to do the things that we do, but in recognition of, and that means that all of our salaries are paid by the taxpayer, that the government, on behalf of those taxpayers, has the absolute right to do this. And it is for us to respond in the most effective way possible. Chair, I'm not going to say any more. Happy to take questions on that or other items that are disclosed in the report.
Thank you. Andrew?
Thanks, Graham. Before coming to your report, can I just, on the back of your comments, Chair, about the incident last Monday, just on behalf of all of the agencies that were involved in what was up to that point an incredibly positive, joyous occasion across Liverpool, both with the big weekend, Radio 1 big weekend, and the Victory Parade, and then subsequent arrival of the Cunard liner, just all happening within a few yards of this place. Which of course ended in a horrific incident. And I just really want to take the opportunity to reinforce your point about the contribution of the emergency services and the NHS staff, both on the scene, and the response was absolutely remarkable and incredibly speedy and brave, because they didn't know the context in which they were faced with at that time. And then of course the subsequent care that was provided to the victims, not just in hospitals in Liverpool but across the region, and all of that undoubtedly saved lives, undoubtedly. Graham, I know you don't want tributes, but can I just thank you as well for your sort of service, and as the chief executive at the time, the integrated care system in Cheshire and Mersey has been established, and on behalf of local government, just thank you as well for the strong partnerships that you've established with all 9 authorities in this area, and you've paved the way to what I know will be a continuing strength of the NHS partnership with local government and other partners in this region after you've left that legacy. Just one point on the report, Graham. I think that there's clearly a huge pressure, quite rightly, on NHS costs, and I know it's been challenging to establish the deficit target that we have, and we'll sort of frame our work for this year. Looking forward, there is a strong emphasis on this concept of fair shares. And I understand and know that the executive of the ICB need to work within the framework in which that's established at national level. But I think for the board, and for particularly those of us who need to support the political leadership of the City region and Cheshire and Merseyside more generally, this concept of fair shares does need to be unpicked a little, and I would welcome a factual briefing note from the team to understand the formulas that give rise to that concept of fair share. Certainly in local government, since the new government came in, there has been quite a substantial change to the way in which local government financial allocations are made in favour addressing an imbalance that had accumulated over the last 15 years, with some adjustments made to support those authorities facing the highest level of social and economic challenges. Well, I don't think we've seen that in the NHS. So it's a formula that was set by the previous government, and certainly in advising our political leadership, I would appreciate a factual note from the team about the formula that determines fair share, just to assure us that, you know, as we're working towards that as a target, it's a target that properly represents the circumstances that we face in this region.
Great.
Can I respond briefly now? But we will provide that detailed briefing for you, and I'm looking at Mark because the responsibility will fall to Mark to do that. The formula that is used for funding of the NHS is very open, very transparent, much publicised. It was changed about 10 years ago, and this is where my memory gets vague. It might even be longer than 10 years ago. And at that point in time, they reduced the emphasis that they placed upon deprivation, and they increased the emphasis that they placed on straight morbidity. So, i.e. there was a greater recognition to the average age of death in your population rather than the deprivation suffered by the population. Now, because that was done so long ago, I wasn't here in Cheshire and Merseyside, this organisation didn't exist. I don't know what the impact of that was, but you are absolutely right. The local government funding formula has been changed. The NHS funding formula hasn't been changed. But when it then comes down to fair shares, there are three lenses that we need to look at this through. So one, do we think that we have our fair share compared with other parts of the country? And are we making adjustments to get back to within that, or are we using avenues to lobby for changes to the formula? Secondly, the way the formula is constructed, we are able to take that formula down to local authority level and below. So it would be really important that in some point in time in developing strategies over the next 3 months, that we are able to say to the board, are we spending the right amount of money in Liverpool as opposed to Knowsley, as opposed to St Helens, and so on. Yeah, but the other thing that I would expect the board to tease out is then a segment analysis of that spend, and to say, are we spending enough money on primary care compared with hospital care, community care, you know, compared with mental health care? And again, each of those aspects and angles will be really important. And again, I leave you with statistic that Anthony has often shared with the board. We have the third highest number of general and acute hospital beds per 100,000 population in the country. And so we will have to think about, are some of our answers in really making sure that we push forward schemes that avoid admission, that accelerate discharge from hospitals, and that we invest outside of the hospital setting to make sure this system works in the way it should.
Thanks, Graham. Steve?
Just a plea really, in relation to the really good relationships we've built within the systems at place and at ICB level, that we all work together around the financial. we all work together in terms of the financial challenges that has been described in the paper and what you said. At a time when obviously your staffing complement is also under pressure, having those at the same time is not going to be easy. And I think I said at the last meeting, the NHS has no proven track record, psychological culture of having to make cashable efficiencies, and it, you know, to do it in the time scales as described is not going to be easy. So in that context, the ICB blueprint, which is mentioned in the document, we have a copy in the appendices, was developed, I understand, without real engagement or consultation with local government at national level. And you know, we are health and social care, two sides of the same coin, and integration, we've worked really well on that. And that blueprint obviously sets out the terms for the future of the ICB in terms of its function, purpose, scale and size, and in particular its commissioning activities. I just have a plea that the transition committee that you've established in terms of reference in Appendix 4, that we have a proper engagement with not only with local government, with the voluntary sector, to make sure that we get it right on a partnership basis. Because frankly, unless this is done on a partnership basis, it will not work, and we'll be in the same situation discussing the financial traumas of the ICB and the NHS going forward. So it's a plea to get proper engagement through that committee. I'm not asking for membership of that committee, Graham, but making sure there's proper engagement with local government, please. Thank you.
Steve, in short, we wholeheartedly agree. There has to be really deep and meaningful engagement with all partners, local authorities and the charitable sector. The Transition Committee has recognised that and has taken action. Basically charged Cathy Elliott, the new Chief Exec, to ensure that happens in an effective way. I know, Claire, any comments you want to make, because you've been charged with doing this?
Thanks, Steve. And I think picking up on Andrew's point as well, I mean, working with local authorities and wider partners is absolutely part of our core business. And I think it's core business for every item of our business, not just finances, not just integration. So I think you've got the board's commitment, and I think you've got staff's commitment to continue working with local authorities and wider partners now and in the future. I think there are a number of committees that we have that you're engaged with, obviously the HCP and future developments there. So I think we can't do this without you, and you can't do this without us. So I think it's about building on what we've already got, which started with CCGs into the ICB and going into the future. The model ICB, that will form the basis of our work going forward. Obviously, we talked about briefly the financial strategy, and again, I think we do this together. I think that's the key message really from me today. Thank you.
Thanks, Claire.
A couple of observations. So thank you, Steve. I think you're absolutely spot on. I think a couple of things have happened here. An absolute requirement by the government to have a handbrake turn on the increasing consumption of resource by the NHS. Secondly, the speed at which they decided to do this means that the model ICP document is not as specific as some people would have liked it to have been. But I think the other side of that coin is that also makes it permissive. That also gives us the ability to define and design things in the right way for our local services. You note the point about engagement with local government. I understand that NHS England's transition executive team have now reached out to the Local Government Association. They have had at least 2 meetings with them in terms of some of the future design and some of the things that they are questioning whether ICBs should continue to do in the future, some of which may be done more effectively by local government. But the other piece of missing information that we currently have is the publication of the 10-year plan. And I can see, as I read through the Model ICB blueprint documents, some hints and some clues to things that are going to be within the 10-year plan. But the protocols of government is, given that they have the 10-year plan drafted, they will not pre-announce anything that is in it. So when we see that 10-year plan, which again I understand is due to be announced during June, the jigsaw will come together in a more effective way.
Thank you. We're happy to move on. Mark?
Thank you, Chair. I'm going to update the board on the month 12 position for 24/5. The report provides an update for the ICS position, which includes obviously the ICB and all of the NHS trusts within our system. The ICS reported a pre-audit deficit of £201.3 million for that financial year, which after national deficit support funding of 150 resulted in a 51.3 million deficit. This is a combination of both the ICB and the provider positions, which are set out in Table 1 in Section 2.6 and as displayed in the chart 1 in Section 2.7. And just to quote those numbers, so the ICB pre-audit surplus position of 25.4 million, which was compared to a 62 million surplus plan, and a NHS combined provider deficit of 76.7 million, which was against a deficit plan of 62.3. Just to note to the board, obviously we've been tracking these positions all the way through the year. Compared to month 11, unfortunately that was an adverse movement of around 5.5 million, but largely a technical issue at one of our trusts, Mersey and West Lancs, regarding treatment of their PFI costs.
Attention, please.
fitting, really, but carry on.
Attention please, attention please. We have an emergency within the building. Please leave by the nearest available exit. Attention please, attention please. We have an emergency within the building. Please leave by the nearest available exit. Attention please, attention. Please wait for further announcements.
I'll carry on. Thank you. So, as described, 5.5 million adverse movement. Just to say that was agreed in advance with NHS England between month 11 and month 12. There are also a series of other minor movements at organisational level.
Please. Attention please. The fire alarm test is now complete.
Thank you.
And no faults have been reported.
It's good news.
Thank you for your cooperation.
Thank you. So that is the overall position. Obviously, there's a lot more information within the pack, including drivers for those positions at both Commissioner and indeed provider side. And again, much more information there regarding relative measures of workforce, bank and agency expenditure, and increasingly, obviously, where our focus needs to be in terms of efficiency and indeed productivity within our system. I'm happy to take any questions on all of those. So at that point, Chair, just ask the board to note the reported financial position obviously still remains subject to ongoing audit processes, which we hope will be concluded over the coming weeks, and that will be the position for 24/5 financial year. Thank you, Chair.
Thank you, Mark. Any questions or comments? No? Okay, and I just want to take this opportunity, Mark, to thank you and your team, because I know all those additional hours that everybody's been putting in to get us into this position here today, and ability to report in the way we're able to report. So thank you for that. Erica?
Mike isn't here, so I just want to very briefly, week on week, month on month, we need to stay on plan. Within the Chair's report, he's put that at month 1. These are headline figures. We are on plan, but there's already pressure, that, as you would expect, on savings and SIP. So very briefly, I wanted to tell you what we're doing about it. So on a weekly basis, there's a financial controls and oversight. So all the SROs and Mandy and Mark are chairing this, and also the directors of finance regarding their plans and their SIP plans. On top of that, there's a monthly system leadership, which are the trust chairs, their CEOs and their core executives. We then have the monthly finance and investment committee. So they will do detailed analysis of the risk to performance and what remedial actions are being put in place. We then go into escalation potentially. If some of the providers hit any of the thresholds that we've set for risk, they will have more one-to-one engagement. And there are options to then further escalation of board-to-board or our NHSE colleagues. And we've also got to acknowledge that to this point, we've also had PwC involved with a lot of our providers on ourselves to get to this point. So it's just very quickly to sort of highlight what oversight we've got in place to stay on plan. Thank you.
Thank you, Erica. Questions or comments? Andy?
Thank you, Chair. I think just to add on the point Erica's made, I think it's really important that we do acknowledge the fantastically positive engagement from across the system. It's quite refreshing for me coming into the system when at a time when we are in the financial challenge. So that bit about how we ensure we maintain on plan after month 1. I think it's a credit to the providers, particularly about how they're responding across all in these difficult times. Thank you.
Thank you, Mandy. Happy to move on. Thanks. Anthony?
Thank you, Chair. I'll keep the overview brief because I know there'll be a number of questions on it, but just to show that the report, obviously we've crossed that transition of the old financial year and an operating requirements and into the new year. So some of the data you see within the pack is the most available and is judged against last year's standards, and some of the pack that you can see is judged about new standards. So there are new indicators, there are new standards, But because of that transition, we've included exceptions according to where that variation lies across either year. I think if we were looking at the latest position, we can see against the main unplanned urgent care standards that April is flagging as green on the report, but I think we also need to recognise that, of course, that the plans for this year have been somewhat reset in trajectory with an aim for the end of year position higher than where we exceeded. Although there is a slight green shoot there in terms of our non-criteria to reside rate in April was the best that we've seen for some time. In terms of planned care, we are, as Graham had highlighted in the Chief Exec's report, we still maintain our position around diagnostic standards as the first and highest performing ICB in the country. And indeed, against the 18-week standard in March, we achieved our year-end trajectory. Obviously, a much challenge position to achieve in the forthcoming year, where the standard turns to 65% within 18 weeks. Some of which we absolutely know and recognise that cannot be achieved through just more additional activity. It will have to be through pathway redesign, and that pathway redesign and process needs to be done hand in hand with our patients as well in terms of system. So I'll hold there if it's okay, Chair, and I know there are some questions to come.
Thanks, Anthony. Any questions or comments? Ruth?
Thank you very much for the report, Anthony. I just wanted to look at the planned care performance issues. I seem to recall some meetings previously. We touched on a reflection on the gynecology situation nationally as being quite a major challenge. And we talked about looking at the planned care lists in terms of inequality. But I seem to recall there was a proposal to redesign the gynecology service so that more was done in the community and so on. It doesn't come up as one of the actions in the report. And I just wondered where we'd got to in making progress for women in Cheshire and Merseyside.
Okay, thanks, Ruth. And we can provide a more detailed brief on the full content of that particular programme, but I've had an update from the team that leads on that, so that's primarily led by the collaborative programme which Anne covers. So there are a number of developments that have been put in train, and there's more yet to come. So if we take, for example, the ambulatory unit at the Women's Hospital goes live in July. And there are a couple of elements in terms of genuine pathway redesign where we're beginning to see the improvement, and indeed it fares well in comparison with England. So for instance, services have been put in place around specialist advice for clinicians and patients pre-referral. And whilst there's still some work to do in getting the utilisation up, when that utilisation is there, we're seeing that patients are being deflected to an alternative service or being provided advice that avoids the referral into the hospital to the tune of 60%, which compared with England's rate of 38% is very positive. And I think the second metric that we're seeing a real change is our focus on initiating follow-ups with the patient themselves. So our rate, whilst at 6% doesn't sound an extraordinarily large figure, that's 6% of all the follow-ups are now initiated by patients themselves rather than clinicians, and that's double that of England at the moment. But we recognise there's still a lot of work to go. We've got a lot of stuff to do around advice and guidance still in terms of utilisation, new to follow-up rates, some theatre processes as well. But we're beginning to see some traction, and we can provide a more detailed brief to you.
Anne, is there any comments you want to make?
Yeah, I suppose the other issue is there's been this massive explosion in the number of referrals, and most of them are around menopause type of issues. So we you know, as Anthony says, we've both increased the capacity we've got, particularly at Liverpool Women's Hospital, but also we are looking at the pathway so that we don't get so many referrals coming through advice and guidance, but other things as well, different pathways to be put in place to try and reduce that demand. We're also looking at some things. So some places have tried doing like group consultations where we have like a group of women together to give advice, collectively, but also there's a kind of support thing which is quite useful as well in that situation. So we've done a lot of work on both trying to stem the flow of referrals by having more things available in the community, but also then also supplementing extra capacity, and diagnostics comes into it well because there's a lot of extra non-obstetric ultrasound being demanded, which we've been dealing with through the diagnostic programme. So we really have done quite a lot of work on gynaecology to try and get ourselves into a better place than we've been hitherto.
Thanks, Anne. We've got Mandy waiting for a question, but just to put on notice, Fiona, let's hear a bit about women's health hubs. And Naomi, your thoughts about what more primary care can do in this space, because I know you've got some really strong thoughts. Mandy?
Thank you, Chair. Just to add to the situation around the gynae weight, one piece of work we have started building on the work at CMAST is bringing in the learning from others. So Birmingham Women's Hospital has been through a very similar journey around gynae weights, and when you look at our data in Liverpool, it's startling where the delays are around our histology reporting, which is actually contributing to some of our longest delays. So I think that's just an important piece here about how we take learning from others and embed that, because we've got an opportunity there. Thank you.
Great point, Mandy, thank you. Fiona, just some headlines on women's hubs?
Thank you. I'll be brief. I think Naomi and I are very much aligned in our thinking of this, and Naomi's very articulate on it, so I will pass over to her. I think we have done incredibly well with our women's health hubs. We are ahead of most places in the country. We have 7 in Liverpool, 7 in Liverpool, and we have now got them in other places as well. It is challenging. We need to do more on working with our local authority colleagues to do joint commissioning and to get over some of the hurdles about who pays for what, and that will unlock things. But it's that fundamental shift of resources so everything that we've done so far has been secondary care based. We have to shift that resource into primary care. There is a huge appetite to do this, and Naomi will tell you about the appetite amongst primary care to do this, but it has to be funded.
That's well queued up. And I'll come to Claire.
So I think we need to be really careful when we're talking about women's health hubs, because if you look at the national strategy, there are specific targets that those health hubs should cover. In Liverpool, the women's health hubs that have been established are specifically for LARC, which is long-acting reversible contraception, which is funded by local authority and is funded through PCNs and the GP practices. Those LARC clinics have shown significant cost savings within primary care and within the wider system. There has been a number of pilots recently where PCNs worked alongside Liverpool Women's Hospital in order to train GPs in menopause and in order to have a GP with a special interest in menopause. That again has shown significant cost savings. Those GPs have now been trained and are now qualified to be able to provide those services, and unfortunately the pilot has now ended. So those GPs are no longer funded to provide that service, and nor do they then have the supervision that is required for them to be allowed to fulfil those clinics. So whilst I would argue that the pilots have been really successful, it's frustrating that those pilots have now ended and there has been no continuation of those services. Now, there are some networks within Liverpool that have looked at other funding streams to be able to allow those clinics to continue. But ultimately, without that funding and without that collaboration between primary and secondary care, they cannot continue. So I would ask that the exec team and the commissioners look at how do we allow the primary and secondary care to work together and to collaborate to be able to continue these services.
Thanks, Naomi. It's a really good example, isn't it, of trying to follow through on the 3 shifts here. And it looks on the face of it, from what you've just said, there's a win-win, both for patient, triple win for patients, win for staff, and a win for the finances. And these are the opportunities that we have to grab really, really carefully. I know you want to raise an issue, Claire, but just give us a thought on how do we get hold of that, pilotitis that happens in the NHS. Some good stuff happens, and yet it all witters away because we don't continue with the innovations that are developed in those pilots.
So we do have some discretionary funding for some services, and I think it's about how we target it, and that comes back to Graham's talked about the shifts, we've talked about the 10-year plan. I think we have a tendency of not doing evaluation as well as we could, or sort of contemporary evaluation in terms of going from a pilot to a sort of a mainstream service. I think it's something we need to look at as we move forward, because this is a really key example of where actually, as you said, it's a win-win. And I think we just need to build on those sort of things and have a sort of more of a sort of systematic approach to evaluation. I know Rowan's very keen on that, and then build it into our strategy going forward and our investment plans, because it would support the shifts, it would support improved outcomes for the sort of the population, or the female population. So we need to get better at that, I think, is the bottom line.
Okay, thanks, Claire. Let's lock that down as an action for the board to hear in due course.
Okay,
Lee, did you have another comment to make?
I did, yes. Thank you. I just wanted to draw board's attention to page 116, but 26 in the performance report, and not being complacent and recognising that dental access continues to be an issue, and recognise that. But I just want to thank the primary care dental team and our dental contractors, because as you can see from that slide, that we've actually, at the beginning of the financial year, we were, I think, 38 out of 42 ICBs in our performance around dental access for adults, and at the end of the year we were second out of 42. We've got to continue that, but I think that's down to good work. I think it's down to the investment the ICB made in our dental improvement plan. As I say, not complacent, and I do look at all the complaint letters, so I know it's not perfect, but I think it's just worth mentioning. Thank you.
It was, Claire. Improvement in the right direction, so that's good stuff. Any other questions? And just one for me in terms of some of the information that's provided, and it was really prompted by something that Graham put in his report, and that was the increase in numbers of GP appointments. I think, did you say 500,000 in that report? We don't see that type of information here, just generally, but in particular on those areas of focus that we have. Will you have a think about how we could see some of that information? And of course, we'd want to understand the impact of that. You know, is that the wealthier areas getting more access compared to the more deprived areas? Let's put some sophistication to the measure. That'd be really good. Claire?
Thank you. I mean, we do discuss that at System Primary Care Committee, so we'll need to think about how we report back. But there is a new national dashboard and performance sort of scorecard around access to support the June plan that's going in around variation in GP access. So that will go through System Primary Care Committee. So maybe in July we can bring a sort of a more substantive chair's note from that committee and share that information with board.
Excellent. That's really good. And let's understand how we incorporate it into our core data set so that we can see it at board level. Thank you. I've just realised I didn't give an apology, which was Tony. Unfortunately, Tony is couldn't come to this meeting because of a family issue, and you can see that he's here to report on the Quality and Performance Committee. The paper's there for you to see. Were there any questions or comments on the paper? No. Okay. Thank you. And again, the Audit Committee paper. People, any questions or comments on the Audit Committee? So for you to note. Okay. Primary care, Erica.
Very quick, thank you to Sarah at the back from Health Watch for all the 9 Health Watchers. So we've had the report into primary care for what it feels like to get GP access. So this is a piece of work that we commissioned, and it's looking at the measures that we've put in for PCARP. It's just so you know there are challenges. And a full report will be coming to the July board with what the plan is and also what Claire was talking about there. So, but thank you. It showed the reach, certainly, of Health Watch and the voice that we got. So thank you.
Excellent, thank you. Sarah, any comment on that?
No, just that it matches what we all as the Health Watchers hear day by day from patients who are still finding it very challenging. So we see the numbers about the additional appointments, but the experience can still be very, very difficult of trying to get through, trying to get an appointment. And that experience is felt differently by different people depending on their circumstances, their ability to access online, and a whole range of factors. But hopefully the report will make that really clear when you see it.
We missed an agenda item in this section, which was the report on the SpecCom committee, and I'm going to ask Ruth just to give a verbal update.
Thank you very much. Just to explain, I chair the North West Joint Specialised Commissioning Committee, where it covers the services that are sort of commissioned as a joint effort between the 3 ICBs in the North West. There is a AAA report which we'll send round separately afterwards. At the last meeting in April, I just draw attention to 3 issues. We had previously agreed that some of the specialised commissioning staff to support this function would transfer to Lancs and Cumbria ICB in July. Since then, obviously, things have changed and that transfer is on pause because of all the other changes that are involved. Second issue, there was a procurement for adult critical care transfer service, which was reported on in April. We will get an update at the meeting next week of the committee, but I understand in the meantime there were no bidders, so we will be looking at interim arrangements and to consider the way forward next week. And then thirdly, we were advised of a national research project in the specialised commissioning sphere, where the costs of the actual treatment in the research programme is met by research funders. However, it was expected that the NHS would pick up the excess treatment costs following the procedure. And that led to quite a discussion amongst the 3 ICBs about looking into this and what our policy would be and how that would affect our financial considerations. So that was taken away as an action that we need to think about. And I know we've got research on the agenda later. I don't know the scale of how much is going on that we are being expected to cover following research trials, but it's something I think we should look at. They're just the 3 highlights, but we'll send the report round.
Thank you. Graham?
Ruth, thank you. And I say this for the sake of the minutes and an action for Ruth and Claire to follow up on. When we talked about the financial situation earlier and we talked about the overconsumption of resources by Cheshire and Merseyside, one of those areas of overconsumption of resources is SpecCom. And again, only transferred to us a year ago. So obviously perfectly reasonable for it to overconsume when it was an NHS England budget, but they will be holding us to account to bring that back into line as well. Now, our situation may be different from the other 2 ICBs in the Joint Committee, so I think it is important that you secure from the SpecCom leadership team the actions that they can take either around price or volume to reduce the overconsumption of resources in SpecCom within Cheshire and Merseyside. And I think we should probably set a date for that to come back to us in 3 to 6 months' time.
Just to confirm that the team is well aware of the financial situation across the North West, and I believe, and Mark will confirm this, that they have contributed to supporting our position by holding reserves that have been made available to the ICB. However, as part of our 3-year financial plan, we have to integrate our thinking around specialised commissioning into that planning process. It'd be important to include that team in how we look at the whole package.
Thank you.
Ruth, thanks very much indeed. I'd be happy to pick up with you outside of here around how we look at the research part of it. Most grants actually include covering the costs of excess treatment, so it's interesting if this is a different grant design that's come forward. We know that research active hospitals get better outcomes for their patients across the board. Being engaged in research is good for our patients overall. So very happy to pick it up with you. You'll hear a bit more about the way we're corralling and supporting system-wide research efforts, and there may be something that we can demonstrate that in engaging with this helps us get better at it and actually balances out costs. So I'll pick that up with you separately. Thank you.
Thank you. Hilary?
Thank you. Nothing further to add from the report, but just to confirm that the public engagement report was published in March, and it gives a good summary of the issues and concerns and positive outlook of everybody who attended and took part. Thank you.
Thanks, Hilary. Any questions or comments on that paper? Fiona?
Thank you. Because I know that Felicity is listening and had a very specific question on that point. That the report that was kindly handed over to us at the last board meeting, it came in after the closing date. We extended the closing date for submissions for the engagement piece, but it came in afterwards, so it couldn't be formally included in the report, but just to provide some reassurance that the programme board has absolutely used it in planning the next stages of the process.
Good. Thanks, Fiona, and important to say. So, we've got a 10-minute break scheduled now. So we're back in at 25 to. Thank you. Okay, let's kick off again. So, Rowan.
Thank you, Chair. Good morning, everybody. I draw your attention to our next business item, the proposal regarding ICB-funded gluten-free prescribing across Cheshire and Merseyside, funding for prescribing products for those with celiac disease. I know, Chair, that you requested declarations of interest at the start of the meeting. Many colleagues in the room know this already, but it's important that it's picked up for the minutes. Had I made this declaration of interest at the start of the meeting, it would have sounded very peculiar. So my diagnosis of celiac disease was made aged 4, just down the road from here in Alderhay Children's Hospital. And indeed, in amongst my family, now immediate family members, currently total 4, with a diagnosis of celiac as well. I'm one of the very few, less than 2%, who subsequently go on to eat normally, but we very much have the lived experience of managing gluten-free diets within our household and beyond. So, colleagues have the paper in front of them this morning, which details, and I'll just give the important headlines really around this. Currently, we care for just over 13,000 patients with celiac disease in Cheshire and Merseyside, and to about 2,300 of those are getting bread and bread mixes alone prescribed. Previously, other items were prescribed, but it's been restricted down to that following some guidance that is 8 years old now. Not surprisingly, 99% of those patients are exempt from prescription charges, because why would you pay the full cost of a prescription for a single loaf of bread? We already have unwarranted variation. St Helens and Cheshire West withdrew from gluten-free prescribing for bread and bread mixes a number of years ago, and that's been relevant to try and answer some of the questions that have come forward in consultation. Right now, we are spending just over £500,000 on that gluten-free prescribing, and it's relevant to reflect, unsurprisingly, that a clinical working group has agreed with the concept of prescribing, and indeed that's supported by the Royal College of Paediatrics and Child Health. To give some context, nationally 40% of other ICBs have stepped away from prescribing gluten-free products. 2 of them are immediate neighbours in Lancs and South Cumbria, and Shropshire, Telford and Wrekin. We previously brought to board the request to go into public consultation as to our stance on gluten-free prescribing, and I bring back that consultation for us to move to a decision today. It is worth pointing out that initially we had brought to board that we would consider do we do nothing, which has never been our stance. We have always looked to move away from unwarranted variation. Do we prescribe everywhere, bringing a cost pressure? Or do we stop our gluten-free prescribing altogether? That would allow us then to put the money currently invested into that into other areas of health spend. What I bring to board today is, as a result of our consultation, that there are some alternatives that initially pre-consultation we dismissed. And those alternatives are: would we prescribe for the under 18s only, which would bring a cost of about 10% of our current investment? Or would we go further and say we should prescribe for under 18s and vulnerable adults, which would incur about 20% only of the current spend? Those were brought back onto the table as a result of our engagement and consultation activities. In highlight, we had over 1,000 responses, 77% of whom are celiac, who reflected the lived experience of gluten-free foods being more expensive. Interestingly, on the other side of that, those supporting considering moving to withdrawing prescribing asked questions including, is this money that could be better spent elsewhere? And indeed, we do not prescribe for other healthcare conditions such as lactose intolerance or indeed diabetes. And also pointing out that the guidance that we're working to that supported this being 8 years old, the access to gluten-free products is better than it's ever been. It's interesting to note that even in the last handful of months, our budget supermarkets, including Asda, Lidl, others, are now stocking gluten-free bread. It does remain more expensive than cheaper gluten-containing loaves, but indeed that gap has closed significantly, and if you're buying pasta now, it's precisely the same cost. We've undertaken the equality impact analysis. Interestingly, we are not, in its strictest sense, causing discrimination, because the NICE guidance does not mandate that these products should be prescribed. But what did come out under the PSED Part 2 around advancing equality is that children and young people lack the agency to buy gluten-free products, and when they are more expensive, that risks being an issue therefore. And hence, as a result of that consultation, the options to consider prescribing for those under 18 or under 18 and living in deprivation is something that we should contemplate. We stepped into the joint OSC, Oversight and Scrutiny Committees, 3 meetings in total. Our first was really helpful and detailed engagement. The second 2, because follow-ups were asked and questions asked of us, were sadly stepped down at late notice due to a lack of coracy of members at those meetings. But we sought to answer the questions that were asked, which, to summarise, do we know the impact of withdrawing gluten-free prescribing? And indeed, where we looked at the 2 places that have done that previously, we've not seen excess either admissions associated with celiacs or osteoporosis or similar. Do we know whether food banks are good at stocking these products? And how many celiacs are using food banks, which sadly is not data we're in a position to put our hands on. And has there been campaigning to highlight the need for celiacs to follow a gluten-free diet? Certainly not ones that we can find since the inception of the ICB, but always promoting food fairness and awareness of celiac disease is indeed worthwhile, and we would support campaigns that head into the future. I hope that gives a meaningful and insightful summary of the questions in front of us, and now I'm keen that we turn to board. Indeed, our previous sort of move into consultation was based on the exec committee, which itself had been fed by various parts of the ICB, including our clinical effectiveness group, that we should consider aligning ourselves with other parts of the country who do not prescribe gluten-free bread and bread mixes. And I'm keen, therefore, to hear from board if there are questions and queries on this, as we then head to making a collective decision as a board. Thank you, Chair.
Thank you, Rowan. Can I take questions and comments on this? Anne?
That discrepancy you described, Rowan, between celiac prescribing, if you like, and all sorts of other things that aren't, I think is quite an important point. So for that, the lactose intolerance thing, I think that's a similar thing in the sense that there are products available, but those products are generally more expensive. So it just feels a bit like we're making an exception of one disease group, if you like, that we're not making for other disease groups, as well as adding to the argument around we're not doing things consistently, even within the ICB, but we're not doing things consistently nationally. So I guess it just feels a bit like if we continue where we are now, if we do nothing, then we need to be considering all these other groups with other diseases that are just as affected, and it's we continue in that anomaly as well. So I suppose my thoughts would be we should be treating all those groups the same and not having some groups given preferential treatment over others.
Thank you, Anne. Sarah?
Yeah, I'm aware that we're non-voting members on this group, but on behalf of the 9 Health Watches, we're all in agreement that we would support it being continued for children. For the same issues of children having the lack of agency, it's much more difficult to get a child to comply with a special diet if their food looks significantly different from everybody else's. Schools, dinners usually can't provide gluten-free food, so parents are in the position of providing packed lunches. So I have to eat gluten-free food. I don't use prescriptions for it. But I can turn, as an adult, to try and avoid buying bread as much as possible. Yesterday, I went into Aldi's to buy a loaf of bread because I knew I'd need to bring my food for today. And actually, it cost me 6 times more than the cheapest non-gluten-free. Even though Aldi are now tackling gluten-free, it's not bargain food in a bargain supermarket. And for a parent trying to provide packed lunches based on that bread, that's a significant cost. And my concern is that we could be storing up costs as well as health challenges for the future if families end up not being able to provide that food. And we don't know which of the children that are receiving the prescriptions are in families that couldn't afford to provide it. But it feels to us, as from the Health Watches and from what we've heard from the public, to be a risk that we're uneasy about removing it completely.
Thanks, Sarah. Andrew?
Thanks very much. Rowan, you described the process of scrutiny, oversight and scrutiny that was applied to this, and it's which is a very important part of the process, particularly when you have a change like this, which is a material change in the provision of healthcare, that there is a process. It's a statutory process, of course, to overview and scrutinise that decision. It doesn't appear to have been sort of properly completed in this process. Now, there's no criticism at all of the ICB staff, because I know that actually you're very diligent in approaching each of the individual scrutiny panels to get their approval to treat this as a joint process. And then, of course, that meant that the joint process had to then be established, and as you say, it was difficult to do that on a basis that was finally correct. So I think there are some lessons there for us in terms of how the scrutiny process operates here. I've raised this with Knowsley Council, that are the lead authority for overview and scrutiny, and I do wonder whether we should, and I would ask if maybe a member of the ICB team could liaise with Knowsley Council and we could establish some better protocols for overview and scrutiny, because it's not right that something as important as this isn't properly complete in the scrutiny process. Can I also just welcome the equality impact assessment's inclusion of social and economic disadvantage as part of the assessment to this. So we did have a discussion at a previous meeting about whether it was right to go beyond the core statutory requirements of the Equality Act, and I think there was a very strong view from this board, which was that social and economic inequality is as critical as other protected characteristics when you assess the impact. May not be a statutory requirement, but as a non-statutory responsibility of this board to understand the impact. And this is a really good example where that is absolutely critical, because ultimately this is as much about poverty as it is about health. I suppose my only point to make, and I do totally understand the health justification for the recommendation, is maybe some disappointments at the level of mitigations on some of the issues that were raised in the EIA aren't as strong as they could be. And I do wonder whether you might consider some mitigations in respect of a sort of public health response on the wider issue, which a number of people have mentioned, about intolerances, food intolerances, as they affect families in hardship, which is a very real issue, not just in terms of gluten-free, but other forms of food intolerance and allergy, where the additional economic cost for those families is relatively significant and can push families into poverty who otherwise would be able to make ends meet. So I do wonder whether some resources is set aside from the savings that might be secured from this in order to establish a process and procedure for supporting those families as far as possible, either through a public health response or a primary care response. And that would help at least to mitigate some of the impact of this recommendation.
Thank you, Andrew. Ruth?
Thank you. I think this has been a comprehensive piece of work, recognising the issues about scrutiny. And I think there's a clear case to harmonise our policy position. I was looking at this through the lens of inequality, and one of the areas I was concerned about is that thousands of people in Cheshire and Merseyside rely on food banks and food pantries for their shopping, for their groceries. And in the consultation process, have we established whether or not food banks and food pantries routinely have gluten-free products available? And if not, is that one of the mitigations that could be applied to make sure the most vulnerable do have guaranteed access through those mechanisms? Looking at the options, I was starting to move towards the argument I think that Sarah was making, that really children under 18 perhaps should be included in this policy, particularly given the level of child poverty that we face in Cheshire and Merseyside. Families are struggling generally, and I think I would suggest that we move towards that as our preferred position.
Thank you. Mandy?
Thank you, Chair. Just a comment more than anything. I think it's really important the board appreciates we are not the only ICS now to progress this. So your point, Rowan, others have gone further, quicker with this policy. I think it's more comment about how we ensure whatever the decision is, it aligns as well, though, with what our neighbouring systems are doing in Greater Manchester and South Cumbria and Lancs, as well as wider systems. I'm not sure if they have looked at children, younger people being exempt from this.
Thanks, Mandy. So let me just go to Ellen.
It's not a weekly thing. You can't access food banks every week.
Sure. Let me just. I'm going to ask Ellen to bring that. You can comment on that for us, Ellen.
Yeah. So the voluntary sector, obviously, food banks are a significant part of the work of the voluntary sector, and the Combined Authority, the Liverpool City Region Combined Authority, have just are enabling some research. This particular question is not part of that research, and I think that perhaps I can certainly take that back and see if that can be included. There isn't research around food banks and availability of not just this area of food priority, but other. It is a generalised package usually, and I think, as our colleague is noting, usually through the Trussell Trust there is particular policies around the way that food banks can be accessed. Of course, there are other ways that we can do that, but it certainly should not be. It is becoming a statutory provision. It feels like a statutory provision that isn't a statutory provision, and I think we need to be really careful not to lean into that too much.
Okay, I'm going to just ask.
I just want to clarify, food banks are for emergency provision. I absolutely agree with the comment that was made, but I included food pantries in my comments, and food pantries are a regular source of people having affordable shopping, which they pay into.
Ruth, I think you're absolutely right, and I think I'll see if we can delve into the pantry, because I think that's the area that perhaps we can have the greatest impact potentially.
Thank you. Laura?
Yeah, I just think it's important for the board to remember that we've got 2 of our places who've already made this decision and don't include children in their decision. So families have already got used to not having gluten-free prescribing in those places and have found other ways to cope. We have significant areas of deprivation in those 2 places, and we've already been through this. So we need to learn from each other, working with our local authorities. We have a Poverty Truth Commission in Cheshire West, and we work with them around access to food. So it's really important that we're learning from where we've already made these decisions. Thank you.
Claire?
Thank you. A couple of points. The healthcare partnership, one of our priorities is children and young people, and obviously one of the conversations we have continually is around child poverty, and we know there's going to be a national strategy coming out soon. So I take on board all the comments, but I think we just need to recognise that when we're making our final decision in this, please. Then my other point was just around the joint OSC and doing some further work. So Andrew, happy to have that conversation. We will have a number of similar initiatives like this coming through, and I guess one of the things we need to learn probably as a board and as an organisation is whether we should package some of these together, and rather than go piecemeal to OSCs and do piecemeal consultation, whether we do not such a big bang, but we do some of these together, and then you can, there's a sort of a consistent approach to it. But we also have a number of major service change initiatives coming through. If you had mentioned Shaping Care Together, there will be a number in the coming months, so we need to get that relationship right between the ICB and OSC, so that we don't need to go 9 times to separate OSCs or a mixture of the both. So happy with Matthew to do some further work with the local authorities on that. Thank you.
Thank you, Claire. Erica?
All of these decisions are going to be really difficult. I am minded towards option 4, which just gives the, the monies for children and young people. I think it is a compromise. My only thought there is, the 75,000, is that actually the best money that we can spend in that children and young people? What are we comparing it against? I'm not clear that that is absolutely the best way to spend that money, but we do need to make sure we've got a really good package for our children. Thank you.
Hilary, is that you wanted to come in?
No, sorry.
Okay. So I'll sum up at the end, I think, what I'm hearing. Do you want to go next?
Yeah, just to say I welcome the approach to having a strategy within NHS contribution to food poverty. Claire, you alluded to that through different programmes. In making this decision, we are going to withdraw an asset from families, and it's about how do we manage that risk while we develop another approach to food poverty if we indeed go for option 3. So I would suggest that this is managed, so we do, as an interim perhaps, include children under 18 and then move to a broader strategy in due course when we're able to do that, to manage the immediate risk of people having this asset withdrawn for them and pushing people further into poverty that wouldn't be otherwise.
Thank you. Are we good? Yep. So right, I'm going to just pose some questions to you.
Okay.
So what I'm getting a sense of is, overall in principle, option 3 could be right. However, what we're all concerned about is this issue about food poverty and how it impacts on different segments of our population, both elderly as well as children and young people, because we know why I've just said that, and we feel uncomfortable that we can't see an effective way of mitigating some of the potential impacts of this in a clear and rational way that we would normally expect us to act. And we've heard a suggestion, haven't we, which is to go towards option 3, but understand how we mitigate that and be really, really clear on that impact. And I should have said, I should have declared an interest, I guess, which is I am the NHS Cheshire and Merseyside Children and Young People Champion. I am exceptionally interested in the impact on children who are living in poverty of this issue. But it's more than just gluten-free. It's the wider food intolerance example. So help us navigate a way forward that we think we'll be comfortable with.
Okay. It's fair to say that we would not be acting without precedent were we to support this for under 18. 6% of ICBs currently do. It comes back to that potentially creates a second unwarranted variation, because we're not then doing this for the over 65s, where issues of osteoporosis are potentially more challenging. However, it would align with our thoughts and principles around particularly child poverty. I would say we would take up Laura's offer, where Cheshire West and others have already gone through this journey and have therefore had to manage the impact and risk of that. I don't know if there's any comment about what you've learnt from that to share with board that would reassure our ability to mitigate some of this. Thank you, Laura.
So we have a particular working group particularly involves the voluntary sector around access to food, and it's included within there. So it picks up your point really around not relying on the non-statutory provision and thinking about how do we ensure there is access for people. So I can certainly look to share that with the places. I'm sure St Helens have got innovation as well that Jamila can play in. So we'll look to do that.
And certainly Celiac UK, who are a well-established and very coherent group, would be those that we would turn to and work with as well, and indeed with our Health Watch colleagues who've got first-hand experience. So I don't doubt that we can navigate our way through this following previous process that's been done in Cheshire West. Thanks.
Thanks, Laura and Rowan. So Graham's just given me a steer. Let's hear what people think about this. So we go with option 3. In the places where, 7 places we think it is, where under 18s are currently receiving gluten-free foods, we continue that for 6 months. But within that time, we work with the DPHs to understand what our overall strategy and plan should be around food poverty, and in particular focusing on gluten-free. But we give that a timescale of no more than 6 months. So we've got.
What? You all should be ashamed of yourselves. You've got no idea. You're all sitting here talking about difficult, uncomfortable. You are taking food out of children's mouths. The chair of the Joint Scrutiny, Jane Corbett, who I disagree with on probably 80% of the time, has actually written in saying the impact. This area has got some of the poorest areas in the country. You're handing a statutory duty to charity, back to Victorian values. You're a bunch of Marie Antoinettes. You all should be ashamed of yourselves. Well said, Leslie.
So so people have just heard what I've said. It's option 3. Period of time, 6 months, no more than 6 months, to get to a better position for supporting food poverty. People comfortable with that?
With the 5th richest economy in the world.
Okay. Thank you. So we'll move on from that. Fiona, COVID.
Thank you. Long COVID. So this is on in your packs. Why are we here? So we have been reviewing our long COVID service over the last 6 months or so, and board will be aware that our current multiple hub service has been stopped, and we have been looking at all of the options available to us to make sure that we provide for the needs of the ongoing population of patients who are suffering from the impact of long COVID. I'm going to take the background of the paper as read. I want to take an opportunity to thank the commissioning team, Alison and Judy, who have done a lot of engagement with members of the public, members of national groups such as the ME Society and the Long COVID Society, and local people with lived experience. They've also done a very thorough review of the evidence available to us to help us make our decisions. So all of that led us to a point where we had 7 options that we were considering for future services. Those 7 options were taken through our clinical effectiveness group and then to our executive committee. The feedback from the clinical effectiveness group was shared with our executive team, and the executive committee reduced the number of options for consideration down to the 3 that are in your paper today. Those 3 options build on each other. So the first one being an online option will appear in option 2 and option 3 as well. Section 6.5 has the feedback from the stakeholder group, so I was lucky enough to be able to go and join the follow-up stakeholder group where we took the options that we were considering. So we took these 3 options and had a very in-depth discussion with our stakeholders, public, that I've just mentioned. I was really, really impressed with the level of knowledge, the way that, particularly from our national colleagues who've done a lot of work and campaigning on this issue. And I was really struck as well by how well some of our public and our patients with lived experience were able to tell their stories, and that's been really helpful for me in thinking about the 3 options that we've put forward. If we do not provide some form of service to support patients with long COVID, and you'll see that there will be financial savings, quite significant financial savings on paper, but it's really important to say that in reality there will be a lot of hidden costs associated with that, because those patients will still access other services that are not fully commissioned, particularly primary care. Those patients will have an increased number of appointments in primary care, so there will be a hidden cost if we don't provide something for these patients. I wasn't going to go through the options in detail. The information's in the pack. So what we're asking today is for the board to note the engagement and research process that we've undertaken today to get us to this shortlist. What the executive committee has recommended is that we go away and do some more work on option 3. So we're looking for the board today to endorse that recommendation of the executive committee. What that will allow us, if we can do some more work on option 3, is it will allow us to work with the potential providers to make sure that we develop a service that meets the needs that our stakeholders are telling us they have, but is the most cost effective. Given the financial position that we're in, it is the most cost effective service that we can provide. It will also mean that we're looking to do some harmonisation, because there is an unwarranted variation. Patients don't have equal access to the services currently, and this will allow us to make sure that we address that as well. And I'll stop there and take any questions.
Thank you, Fiona. Questions or comments? Naomi?
Thank you. I think looking at this patient cohort, there are a significant number of patients who are still severely debilitated by their long COVID disease. It's not unusual that option 1 is asking GP to do more with no additional funding, and we are already doing that. We are providing support for those patients. There are already clinics within the Liverpool area that have been disbanded, and those patients have already been referred back to GP. Now, the understanding initially was that those patients would be referred on to their kind of predominant services, so example, respiratory or cardiology, depending on their main symptoms. That has not happened, and those patients have now been left to be re-referred into services, which is just far from ideal. I absolutely support option 3. I think not just for patients with long COVID, but we've got a significant wait for patients with conditions like ME, CFS, and some fibromyalgia patients as well. So I would ask, there needs to be something in place for these patients beyond general practice, but also then to be able to support general practice and caring for these patients.
Thank you, Naomi. Claire?
So a similar point to Naomi, really. I support option 3. I think it's the best option considerably, but I would ask that whatever model is worked up and whatever pathway, we do include the shift. We need to think about the shifts, and we need to think about within the budget that all parts of the provider are reimbursed and supported. It isn't just the sort of the lead provider. They may want to have a sort of a relationship with some of the other GPs or whoever. So support 3, but I think we need to look at all elements of the pathway being funded properly.
Okay. Sarah?
Yeah, I should probably declare interest in this one. I had long COVID myself for a year in 2020, and that included months being completely bedbound. Fortunately, I've made a full recovery, but I know a lot of people that I was in contact with back then who are still incredibly debilitated, as Naomi points out. On behalf of the 9 Health Watches, we would strongly support option 3 of the options that remain on the table, but we would ask that there is learning from what worked with the previous services. So the Health Watches in Merseyside, or most of us, which were covered by the Merseyside service, did some engagement around that, and there was a lot of learning from patients about what really mattered. And the way that service worked compared to how the previous short-term service which was hospital-based had worked. And a lot depends on the expertise of the staff, the willingness to listen, to understand, and it is an incredibly difficult condition to live with a whole range of complicated symptoms. But I also agree with Naomi that there's a need for improvement around ME, CFS and those other similar but not the same conditions. And if we can use this to improve the experience of both cohorts of patients, then I think that would be ideal.
Thank you, Sarah. Anne?
Just one of my hobby horses about doing things online. I just always think, option 1, the online thing, disadvantages the vulnerable, the elderly, and those people who can't afford to have internet connections and stuff like that, just haven't got the wherewithal to do it. So I'm always really anxious about having these online solutions that will exclude a whole load of people who may well need these services the most.
Thank you. So, Fiona, any immediate reactions before we move to the ask of the board?
Just to acknowledge Naomi's point about patients who had been discharged. So all of the patients who were discharged from existing services had a clinical review before discharge. So some of them were referred on. It was a view that the ones that were discharged back to the GP, that was the requirement of them. But I accept that that was a specialist service making that judgment, not a GP. Otherwise, no, thank you.
Okay, thank you. So we're here to seek your decision on the endorsement of the Executive Committee's proposal to go with option 3. People happy with that? It seems a good, positive step, focus service. Yeah. Fiona?
What I should have said was, and also, how would you like us to proceed? Do you want us to come back to board, or are you, shall we take this through the Executive Committee?
Now, unless any board members want to see this come back, I think it should go through the committee.
Thank you.
Yeah, okay, thank you. Rowan.
Okay, thank you, Chair. Our next paper, Cheshire and Merseyside Subfertility, Clinical Policy Status and Options for Consideration. We've worked hard over the last 3 years to bring harmony and have done that across nearly 100 policies now, those that we've inherited from our CCGs. And our policy on subfertility is an extensive one. There's been a huge amount of work, and I'd like to thank colleagues that have done that, similarly as those who've worked hard in the gluten-free space. And what we bring today is to look to consider an interim position to manage our subfertility policy, that we want to take board into a status to consult now, and that we will bring board members therefore at the end of this discussion as to exactly what we want to consult on. And I'll reach that at the end of my preamble, because this will lead into that discussion quite naturally. What we've inherited, despite being a national health system, is essentially a national postcode lottery. We have inherited across Cheshire and Merseyside variation of between 1 and 3 cycles being made available across our 9 places. And indeed the national picture remains one of lottery as well. currently 66% of our ICBs offer a single cycle. Of note, in terms of our nearest neighbours, that single cycle policy is currently live in Greater Manchester, Lancs and South Cumbria, Staffordshire, and indeed West Yorkshire. It is important that we understand what our subfertility policy delivers for patients that move through that care. And it's complex because success rates very much vary by age and a number of other comorbidities and factors. But to give some ballpark figures that are quoted in our papers, and at times our providers do better than this, but some ballpark figures for a 34-year-old female embarking upon treatment, from one cycle 30% will be, or a cycle will be successful 30% of the time. And a cycle is the entire cycle of care from looking to stimulate to harvesting eggs and ultimately implanting embryos. Where patients complete 2 cycles of IVF, that overall success rate nudges up a further 15% to 45%. And where 3 cycles are offered, that offers success for an additional 10%. So we can perceive that it is sadly a law of diminishing returns for our patients out there. Currently in Cheshire and Merseyside, and let me be clear to call this bit out, we've heard much today about the very significant challenges we have as to what we can afford as a healthcare system. So currently we are investing £5 million each year into this mixed economy of IVF policy. We have therefore looked to understand, because through complete transparency, what harmonising that policy would cost us. Were we to harmonise to 2/3 of the rest of England with a single cycle, we would then be spending £3.7 million on this. And so as not to be seen as disingenuous, that means that we would free £1.3 million to afford and invest into other areas. Were we to harmonise to 2 cycles, it nudges our current spend ever so slightly. So currently we spend £5 million, and it would bring a cost pressure of £40,000. Were we to harmonise to 3 cycles, then that cost pressure increases to £750,000 on top of the 5. So 5 million would move to 5.7 million. What I'm keen to get from board today is not a decision as to what we do, but a decision as to how we proceed with this. And how we proceed with this, in the opinion of the executive, is that it must proceed into consultation. And what I'm keen to understand from board members is whether we would seek to consult on moving to a single cycle in line with 2/3 of the nation, or whether we would consider consulting on the question of would we offer 2 cycles. I think another vital statistic to put in the middle of this is, on average for our patients, it takes 1.36 cycles of care is what is delivered most of the time. I'll pause there, and I'm grateful for the support of Fiona as well, working through this, because we can also summarise the impact assessments of some of this too. Thank you, Fiona.
Thank you, Chair. So in your pack, in the full pack, you did have the full equality impact analysis and the quality impact analysis on both 1 cycle and 2 cycles. The impacts are broadly similar. Focusing on the equality impact, there are if we think about our protected characteristics, there are some positive impacts in there. So the changes, you'll also see in the pack that there are some minor other changes other than cycles being proposed in the harmonised policy related to smoking and BMI, alcohol intake, etc. And age is in there as well. So there is a slight change bringing us in line with NICE, has a positive impact on equality access for age. Obviously, protected characteristics of pregnancy, maternity are absolutely impacted, and the mitigation for that is our recommendation that we consult publicly on this. I think the other positive is that a harmonised position is a much fairer and more consistent policy. It removes the Cheshire and Merseyside postcode lottery, which I think is a very important point to emphasise. I just also wanted to pull out the protected characteristic of sexual orientation, and the fact that the policy that we're proposing may disadvantage some same-sex couples, because the current policy requires same-sex couples to self-fund part of the pathway. This is probably the commonest complaint / inquiry that I've dealt with on this over the last few months. The National Women's Health Strategy that the previous government published committed to removing that inequality for same-sex couples over a 10-year period of the strategy, significantly raising hopes and expectations from that group. And as things stand at the moment, that group will not see that benefit with this proposal. It's out with the equality legislation, but we've discussed many times already this morning the impact and the considerations about patients on or people on low income. And we will there is a quite obvious impact there that people on low income will not be able to afford, if we go with one cycle, to self-fund a second cycle. And this will be considered in some detail when we do our public consultation. And they were the main points I wanted to pull out on impact. Thanks.
Questions or comments? Bearing in mind what we're being asked is to consider what we go out, so whether we should go to public consultation and what we go out on.
Sorry, just to clarify, Chair, and you can certainly ask that question, but the clear view of the executive is that we must consult on this, and it's really, do we want to consult on a single cycle, or do we want to consult on offering 2 cycles? Thank you for that.
Thanks for the clarification. Erica.
I mean, Rowan's just clarified that. I mean, we have to go to public consultation is what I assumed, and overriding, I think we have to drive consistency, and if the larger percentage of our other ICBs have gone for one cycle, then I think that's what we should propose to do on the consultation.
Thank you.
Thank you.
Naomi, then Ruth.
I think this is a really emotive topic, and is so important to so many people and to so many families, that actually it's really important that we get this right. I think that nationally we have a postcode lottery. Within Cheshire and Merseyside we have a postcode lottery. We have patients living on the same road who can have varying levels of support and service provision, which is not fair. But I think the point I wanted to make is actually, if you take the emotion out of this, and if I use the example you use all the time, Raj, of a hip replacement, if hip replacements were only 30% successful, would we still perform them? And I think it's an important question to ask when we're looking at, ultimately, the NHS is a finite resource. It's important that we use that resource efficiently and effectively. Now, I absolutely agree that we should be offering IVF, and it is a really important part of healthcare for our patients and for our families. But ultimately, a 30% success rate needs to be taken into consideration when we're looking at the distribution of resources.
Thanks, Naomi. Ruth?
I agree that we need to address the unacceptable variation. So I think it's right that we should be looking at this policy. Yes, of course, we should consult. In a sense, even if we express a preference for one cycle in the consultation, my expectation is that people will consider 2 cycles and 3 cycles and will be aware of the clinical recommendation of 2 cycles. So it's disappointing that we would be specifically saying we're not going to accept the clinical advice, but I would imagine it's going to be all part of that public discourse anyway, that people will have the information as to what's being recommended. You know, I agree that if we're going to offer it, we should ensure that we get the best results. And I think that's important for those people affected. Just finally, a question really, which is, what's the scale of this service? We've got some financial figures and so on, but how many cycles do we actually provide across Cheshire and Merseyside each year? We sense of the scale of it.
So it's close to 1,000 in terms of the number of cycles that we are currently providing across there. And it's fair to say we are, due to the complexity of this, necessarily focusing on averages here, because there is a very significant sort of distribution curve of what happens out there currently. But there's easily close to... so that's the number of cycles. It's quite difficult to then extrapolate that back to number of patients because of that distribution curve that we have. But if you work on the basis of, if on average it's 1.36 to be effective, we think we're close to 650, 700 patients, because most of them, you know, are needing 1.36 cycles, which takes you up to the 1,000. I want to be careful not to try and reverse model to such a tiny degree that it becomes no longer credible. But we think that overall it's between, you know, round about 700 patients per year across the system on that basis. Thanks.
Trish.
Thank you, Chair. I certainly support the need for a harmonised approach and policy here. I'm just mindful of people who are already going through this process, and I think we need to think about how we make sure there's some transitional protection for people. It's a very stressful process, so the communication of this is critical, and it's something for us to think about in whatever decision that we eventually make. So they'll be part way through a programme, a pathway, and I think that's important to just keep that in mind too.
Good point, Trish. Thank you. Graham?
Thank you, Chair. I could have intervened on any of the last 3 items and made this comment, but whether we like it or not, we have to make difficult decisions. You've heard me talk about the kind of handbrake turn on the growth of the use of resources by the NHS, and we can't do this without actually considering the financial impact, and we've got to be really honest that one of the motivations on this is to reduce the spend in this area. I therefore think that we have to consult on a recommendation of 1 cycle, because it would be disingenuous for us to just put this out as a completely open consultation process, tell us your views, when we know that one of our motivations is to harmonise with other places and to take advantage of the saving. The other thing I want to say, which we should state really clearly in our consultation document, is whilst we might move to a policy subject to consultation that says 1 cycle, that is effectively our general policy. And like all of our policies, there is a route for people to submit an individual funding request when they believe there are exceptional circumstances. Now, there cannot be exceptional circumstances that we are able to predefine, because if we predefine them, by the ability to predefine them, they are not exceptional. So we have to be really careful not to wander into the wrong space on this. But I think we should be very clear in the consultation document. There is a route for people to come forward and have exceptionality considered. But we can't define that exceptionality.
Thanks, Graham. Helpful. Any other questions or comments? Okay, so we can see the recommendation that's in front of us, which is to go out and consult on option 2. And I'm seeking your support. And I'm going to put this caveat on it. I am concerned that when we do go out to consultation, we take this siloed approach. Claire talked about it. What I think I'd want as a member of the local population is a broader understanding of why we are doing this. The point Graham makes about the opportunity cost of investing in one service versus another is a really, really important consideration that I think our communities would want to understand. But I also recognise how difficult it is to explain, not just to the general public, but to those of us in the service, how that works. It's an extraordinarily difficult thing, but that's what we are doing here. We are spending money currently, overall, globally, that we haven't got. We have to get a loan for, £178 million, and that's to the detriment of services that we might want to invest in into the future. That could have higher priority for the use of that investment of money. Really difficult thing to do in terms of the analysis of it. So, Rowan, I'd ask you to think about how we do get some of those points across in the consultation.
Yeah, absolutely. And just for complete clarity, Chair, because when we're numbering our options as well as numbering our cycles, just for colleagues at the board, so I'm hearing a consensus that reflects us being authentic, honest and coming into harmony nationally, that we would go to consult on offering a single cycle of IVF. The reality of our financial situation, our difficulty to afford the services that we deliver now, I think is vital that we remain authentic with our communities when we go out and consult on this. A challenging and emotive subject though it might be, and it is our responsibility to make best use of the monies entrusted to us. Thank you, Chair.
Thank you. Mark.
Thank you, Chair. The next item on the agenda is around a update on the operational and financial delivery plan for the 25-6 year. So again, board members recall back in March we updated the board on submission of our plan in line with NHS England planning guidance. So today's paper just brings that up to date and sets out the final plan that was submitted at the end of April. And I'm going to take you very quickly through some of the aspects. Again, we've touched on a number of these, notwithstanding Graham's Chief Exec report, touched on some of these numbers as well. So the ICB submitted a 50.3 million surplus plan, offset by a provider position of a 228 million deficit, which resulted in a 178 million system deficit plan, which was in line with the maximum deficit control total as set by NHS England for the 25-6 year. That plan didn't initially meet the NHS England expectations. You'll recall from, again, some of the press coverage that Graham alluded to, and we were asked to improve our position between the end of March and the end of April, hence why the paper is partly with you today. The paper also sets out some wider aspects of the 25-6 operational plan, which obviously the plan is not just about the money, it's about the service delivery and the performance measures by which we're judged as an NHS and indeed as a local system as well. And again, the paper includes lots more information on a number of those aspects, and I will touch shortly on some of those. I should say at this point it is truly a system effort to deliver this plan. It is about the collaboration between commissioners and indeed providers to make sure that obviously we get over the line on this, and making sure that that plan not only meets but also exceeds some of those mandated performance positions, and again some of that detail within the plan. In terms of some of the highlights, in terms of the finances, we plan to spend just over £8 billion in the 25-6 year across a number of different areas, across primary care, community care, mental health care, and indeed secondary care services. It also includes some aspects of specialised commissioning services, which again colleagues have heard earlier today has been delegated to us from NHS England now, and indeed there will be more work to do on that basis about how we join up those services across pathways increasingly in times to come. That planned expenditure does rely on a significant amount of cost savings across both, again, provider and indeed commissioner side within the 25-6 year. So some of the figures are £572 million of notified cost improvement and or indeed efficiency savings, broadly broken down 433 on the provider side and indeed 139 on the commissioner side for the ICB. The key drivers for those savings areas are, as you would expect from the ICB, areas of prescribing, packages of care in terms of continuing care and indeed mental health care packages, and indeed managing demand to make sure we have a good system plan and approach to managing demand within the system. On the provider side, notwithstanding the challenges that indeed we face on delivering some of those plans, but key to delivery of cost improvements will be impact on workforce numbers and indeed costs around bank and agency, and indeed improvements in productivity and efficiency in order to deliver those standards. Should just say that alongside the revenue allocation, the system has been allocated just under £200 million of capital allocations in order to improve infrastructure, and an additional £155 million of additional national programme allocations across 5 different categories, which again we're working with the national team. There is a small residual amount of capital allocation that hasn't yet been allocated, but again we're working with the provider system to ensure that that's in line with delivery requirements for the 25-6 year. If I just touch briefly on some of the operational aspects again within the report, pleased to say that the revised plan did meet all of the national expectations across the 4 broad headings of elective care, urgent and emergency care, mental health and primary care. So some of the key measures there are around our referral to treatment standards, including the percentage of patients that are treated within 18 weeks, and indeed some of the cancer standards around 62 days. Pleased to say that all but one of our providers have submitted a compliant plan. That organisation is Liverpool Women's, which is down to recognised operational constraints in some of the standards again, and we're working with that provider individually to help support improvements in that area. Pleased to say in urgent emergency care, so we have a plan to aim to reduce corridor care, improve A&E performance, and indeed reduce ambulance handover times in line with national standards. For mental health services, again, an increasing focus on reducing out of area placements and improving access to children and young people into our services. One of the most important factors around, similar to the acute sector, about reducing inpatient stays and delays out in the community for segments of our population. And then last but not least, around primary care. So again, you've already heard Claire mention earlier today about dental appointments, dental access, but increasing around general practice services, and also linked to that about how we improve contractual oversight and support the digital transformation that we think will help support improvements and efficiencies in that area. In the paper, there's a lot more information. Erica mentioned earlier some of the aspects of oversight that we've dramatically increased in the last 6 to 8 weeks. So I won't recap those, but just to stress there is a lot more oversight now in the system through our Financial Control and Oversight Group. Myself and Mandy meet regularly with both providers and indeed members of the ICB to ensure that we are de-risking the plan and indeed moving forwards. There is a section within the paper in section 12 around the main risks to the system, so I thought it was worth just highlighting those sort of 5 key areas. One, obviously, that the system needs to work collaboratively and together to achieve system financial balance, so that's the 178 million deficit within the financial year, so that we can receive not only the resource equivalent of the deficit support funding, but obviously more importantly, to some degree, the cash equivalent of that, which is a significant risk for us within the financial year. I should say that, and I think this is probably well recognised, that within the plan there is a significant amount of in-year risk that all organisations, ICBs and indeed providers need to manage in order to deliver that plan. And a number of those aspects are being managed through the processes that I've just highlighted, and in particular the work of the System Financial Control and Oversight Group, so where we look at themes for improvement using the measures and the benchmarks that we have available to us. I think that's been a welcome addition in the last 4 to 6 weeks by all of our system in terms of moving that forwards. And then just lastly, to touch on the points again that Graham has already raised, significant changes we think ahead in terms of allocation processes, the way that deficit support funding may or may not be treated nationally, and obviously the impact of that, not just in Cheshire and Mersey, but across the wider North West. And then those longer term sustainability issues in terms of our resource allocations, the fact that we're an over-target system, both from respective ICB allocations, but indeed specialised commissioning, again, as previously touched on. So a number of risks that are in the paper. Hopefully, Chair, that brings the board up to date with our plan submission. We're well into focus on delivery and de-risking the plan as touched on. And again, I know we'll possibly talk about that. Obviously, Anthony is with us today to talk about any aspects of the operational plan, but I hope that updates the board, Chair, on where we're up to as at the end of April. Thank you.
Thanks, Mark. Any questions or comments on this? Ruth?
Oh, thank you very much. Obviously, I recognise the scale of challenge that we've got on the financial side, and I know how much work you've done to try and balance the performance issues with the finances. Obviously, this plan is how the board will hold the officers to account for our work this year. Some of the delivery items are really specific and tangible. I was a bit more concerned that in the list of requirements from NHS England, there are some areas where we don't really mention what we're going to deliver, and I'm particularly going to focus on the quality and safety, address inequality, shift prevention. There are some specific requirements of us, but I don't see in our plan anything tangible that we could say we're actually going to commit. Recognising the money is tight, but how are we going to hold ourselves to account for having delivered something? And what that might be. There's sort of general references under some of the other areas, such as cancer, about inequality, but it doesn't say what. So that was my general question. On the urgent care, there's a commitment to reduce corridor care by 50%. And I suppose it just made me sort of sit back and say, does that mean we're accepting the fact that corridor care continues? And I guess my question is to Anthony in terms of how much corridor care have we got now in May, when it was really meant to be a sort of urgent response to huge surge in pressure over the winter, but has it now become part of what we do, and how do we get out of this? Because it's clearly not a respectful way of treating patients. Thank you.
Thanks, Ruth. Respond to the overall question, then we'll come to Anthony.
Thanks, Chair. Thanks, Ruth, for the question. Yeah, I think partly as a result of the planning process that we've been through, and obviously with Mandy joining us and bringing perhaps that fresh perspective, I suppose to try and answer your question, we are, I suppose, reviewing all of our expenditure to try and make sure that everything we can justify adds value, that is supporting the agenda that we need to go forwards. I suppose again back to Graham's earlier intervention, we need to make sure that we can justify that spend because we are spending more than our allocation, and again colleagues know that. I suppose in respect to some of the specifics, we do have some pre-commitments that we continue to want to try and support, but the work that myself and Mandy are doing through FCOG and through our internal processes is making sure that we can justify that expense. So for example, on inequalities, we have some existing arrangements and some commitments. We're making sure that they stand up to that test, and if they do, then we can continue on that basis. I suppose what we don't have the luxury of is perhaps expanding or investing more in the way that we would have originally liked, and obviously we need to find the balance of that. Again, to earlier points, very clear to me, and I think I make this point a lot about being proactive rather than reactive, because we are spending £8 billion in our system. We do want to move that money towards the left, to use that sort of expression. We want more primary and community and mental health services that stop that reactive care being provided. I suppose the process that we're currently underway with is trying to make sure that we can analyse what we are spending and how we can move that money in the most effective way. I think, again, we've made the point, we are still emerging from that financial landscape of post-COVID and block contracts and trying to move back to more of an activity-based system as per national guidance that will allow release of funds in a way that perhaps we haven't been able to in the last few years. So there's a number of moving parts, but we're trying to move towards that, and this comes back then to the 3-year plan or the 5-year plan perhaps. We're on our way with that, but again, I suppose the last month of activity, conversations with NHS England, PwC with us obviously at the moment in the system, we're just taking stock of where does all that leave us. But the generation of that plan obviously can't come soon enough, making sure again all partners are on board and what we're trying to do to move to the left. I think when we've completed our initial phase over this month and next month, we should have a more granular ability to state, and these are the values involved. I suppose back to some of your questions then, in terms of the things that we're trying to support going forward.
Let me just pose the question slightly differently. So I think there's a technical ask of you, which is to list somewhere, and it should be in the operational plan, or the must-do operational milestones or objectives that we're expected to deliver. So it's absolutely clear. And then following that would be your risk assessment, some of which could be, we can't afford it. But I think that's what Ruth is asking now.
There's certainly clarity about, even if we're going to stay the same this year, we should be explicit that that's the choice we're making. I wasn't making an argument for, I mean, I'd love to, that we should spend more and more on inequalities, but we're spending £8 billion. So what is it on, for example, Core 20 plus 5? What are we actually going to deliver this year? It may be the same as last year, but what we need to be mindful of is that we're not going backwards. And by making choices, we're not shining a light on the consequences of some of those choices. So it's really about the whole 8 billion and how does it come together to deliver the specific things that we want. I accept we may not make as much progress as we'd like, but if we're not measuring it and showing it, then we won't know what impact we're having on some of these really key issues, really difficult but key issues. So it was really quantification I was looking for. You're absolutely right.
Okay. Claire, did you want on this point?
Just on this point, so if you remember, I brought the annual delivery plan to board last time and we signed it off, and we had the 4 key priorities and then the enabling strategies. I think perhaps maybe in July, hopefully once we've got the 10-year plan, we can bring that back in terms of the detailed plans underneath, because we signed off the high level plan, but I think there's what's underneath as well, and bring that sort of, we do have some of that worked up already. We didn't bring it here because of everything else on the agenda, but the work's going on. So we can bring that back and hopefully do a bit of a cross-referencing maybe with the 10-year plan, if that would help.
So Graham, is it on this point? Do you want to? No. So I think what we're asking for, Claire and Mark, is, and I'm going to call it an annual plan that clearly articulates the must-dos that we're required to do from NHS England and our other regulatory bodies, understanding what we think we're going to invest in those areas and understanding the risks. Claire's point about the NHS plan is really important, because things will change mid-year, because the NHS plan will become real as soon as it comes out. So there could be things that are going to influence the plannings and priorities guidance that we've already been given. So I think that's important. Looking towards the July board to do that, if the NHS plan is actually delivered in June, I think would be a good thing. I'm going to go to Anthony. Have we normalised corridor care, and what's it like in May?
So I think it's key to remember that corridor care is not one of the national operational metrics. Indeed, it's not accurately recorded in any system. We do record that on a daily basis, and we see on average 127 patients receive care on corridors within the spread of accident and emergency departments on a daily basis. The primary focus for the NHS's operational planning is to ensure that patients access really readily emergency and emergent care at the point of demand. So the biggest metric there is the ability for ambulances to respond to a 999 patient. And there's a key metric around there of 30 minutes. In turn, the next measures are around the abilities of accident and emergency departments to treat the vast majority of patients within 4 hours. And indeed, a bit of a backstop measure that no one should be spending more than 12 hours in that department before going on to their care. When a system is managing an urgent care system which is really challenged through high bed occupancy, through high demand at the front door, challenges at the back door through the acute hospitals, corridor care is something that is there as a way of almost balancing the risk. You could eliminate corridor care, but at the detriment of the ability to respond to 999. So this is really how systems are trying to effectively manage the key deliverables. So when you hear us talk about our aim of this year is to achieve a 50% reduction in that, what we're saying is that the UEC improvement plan, which is across the whole of the patient flow spectrum from point of demand to home, and Mandy may want to talk about some of the elements on which we are prioritising on this year to try and achieve that, is that we would also hope to reduce 50% of the incidents in corridor care whilst maintaining delivery of those sentinel metrics at the same time. That's a real challenge. It's a real challenge for many systems, but particularly ours. You can see that in our performance report about where we feature nationally on that. It's also one of the biggest drivers of financial pressure for us. You know, we think roughly £90 million a year is expended on corridor care. So it's the right thing to do. It's the right overall aim to look at improvement across the entire pathway, and it should realise both financial but more importantly quality improvements. So I don't know if Mandy, you want to draw out some of the prioritised areas that we've took from the plan this year, and with Mandy's increased stewardship on where we'll be going this year.
Thanks, Anthony. If I just summarise, conscious of time, because I wonder, Chair, if it's also helpful to bring this back to the board at the next one around the whole improvement plan that we're now about to embark on. I think, Ruth, that's a really helpful question. Are we, my words, not yours, accepting corridor care? Actually not, absolutely not, for the reasons we've already said about not only is it contributing to our financial challenge, but actually we're not an exception from any other system in that sense. You know, we have enough beds in our system, we have enough capacity, enough resource. In fact, when you look at our position, we've invested more in Cheshire and Merseyside financially on urgent emergency care than most other systems in the country. What it has allowed us to do, though, is really take stock of what the various layers are on urgent emergency care. And if I think about our no criteria to reside position, where we know we are without a doubt a national outlier, just in the last 2 weeks we are starting to see inroads in there, and we might want to pick that up in a session later today. So I think in summary, what would be helpful for this board to see is what will be different this year piece. So what is the improvement plan that sits behind the operational plan, and how do we genuinely work towards, when I look at this, I'm not looking at a 50% reduction of corridor care. I am genuinely saying there is no reason we should not be in a position with all our resource now saying we aren't accepting corridor care. If I say my final point, just so that public board's well cited, just today we sit in Liverpool, which is really a fantastic part of the system, but we have to question ourselves that we have 88 patients today in an acute bed who needn't be in an acute bed, and we have similar positions right across Cheshire and Mersey. So I think we've got a lot to go at here to decomplicate our system, help our patients navigate through the urgent emergency care pathway, but getting back to basics, so corridor care is an exception, not the norm. Thank you.
Thank you, Mandy. Any other questions or comments? Happy to move on, and it's here for noting and to note the revised submissions of the 178. could move on. I think it's Fiona.
No, I'm taking this one, Chair.
Oh, okay.
The paper is there for colleagues to see on polypharmacy, and 3 asks of board with respect to that this afternoon, as we are just. Firstly, to note the reality of our position when it comes to polypharmacy, prescribing multiple medications, to endorse the programme of work that has been constructed and is ongoing, and to note that the update on the outputs of that programme of work will be shared up through our Quality and Performance Committee. The position is stark. We are the 3rd highest system of the 42 in terms of the average number of unique medications prescribed to our patients. We are the 2nd highest nationally in terms of patients being on more than 10 unique medications, and the highest in the country for patients being prescribed 15 to 20 medications. It's worthy of note as well in terms of the consequence of polypharmacy that we also sit as the 6th highest in the country for falls resulting in admission for patients over 65 years old. These are not unrelated facts. So much work is undergoing already to tackle this, and in the 24-25 year, £1 million of prescribing spend was taken out by looking to tackle polypharmacy across each of our 9 places. And it really has 3 pillars: that we improve the outcomes of our patients by more effective prescribing, that we look to actively tackle health inequalities because we target those patients most in need who are being prescribed so many medications, and that we improve our efficiency by looking to decrease the unnecessary prescribing, which is undoubtedly part of this already. So the elements that make this up, whether that is GPs being able to review patients using risk stratification, the population health tools that we've embedded, the data into action programme, of which we are rightly proud, allows us to search for our patients and risk stratify them and therefore prioritise. And also our ability to track the impact of tackling excessive prescribing of medications, for example, tracking the number of falls that are then being reported. We've got standout areas of excellence of this already, and we can measure the impact of excellence if you look at the work that's already been done in the Sefton hub, where we've reduced the need for GP appointments by 9%. Almost 3,000 appointments have no longer been needed, and a 32% reduction in attendance to A&E in the 6 months following discharge, because these patients are being actively supported by our teams to look at their pattern of prescribing as they've landed home following discharge and looking to de-escalate that. Of particular note, there are areas of patients who've come in with acute kidney injury where nearly a quarter of them will be readmitted within 5 days. So we know there are groups of patients to particularly target and work with. Optimising inpatient reviews. So as patients are coming in, how can we de-escalate? And indeed, how can we de-escalate on discharge? And that is where having multidisciplinary teams led by our consultants in the hospitals will look to oversee this. And indeed, we've been asked to be part of national pilots looking at antidepressant prescribing, or perhaps more importantly, how we de-prescribe antidepressants for our patients across the system. And it's of note that there's been amazing work, particularly in Liverpool, working with Citizens Advice on prescription, result of which, giving the right support to people out there in difficult times, directly impacts their prescribing of antidepressants. We bring together a community of practice, and this is a central pillar of the work of data into action, therefore. So I would welcome that board note the challenge, the work that is ongoing, and support us and endorse this programme. Thank you, Chair.
Thanks, Rowan. Naomi, Adam.
Thank you. I've got a lot of comments, but maybe I'll speak to Suzanne outside of the meeting. I suppose they're kind of more operational. But from a board's perspective, I think it's really good looking at some of the benefits that we've seen from things like the Sefton Place hub work. You know, 3,000 fewer GP appointments were required. Now, that's not that 3,000 fewer GP appointments were delivered, but they were offered to other patients, and other patients will have been able to access those appointments. So how do we extrapolate that learning to other places? If this is compared to status quo, how do we then say, well, actually, if this is gold standard, we want other places to aim for that? You know, is that something that we're able to do as an ICB? Can we recommend that for other places? With any deprescribing, we need to work with wider partners. So for an example that I gave last year regarding the opioid and gabapentinoid deprescribing, is that patients are reluctant to have their number of prescriptions reduced because it will impact the benefits that they receive. It will also has an impact on things like PIP, on things like their mobility. So on a national level, we need to be feeding that back to DWP. With regard to the consultant-led MDTs, this seems very secondary care focused, but there is a void at the minute between secondary care and primary care and prescribing. It can take up to 2 weeks for a letter to be delivered from the hospital to the GP. The GP then has another 2 weeks to be able to implement those changes. Actually, if general practice pharmacists were part of that MDT, that would completely remove that, and it would also then be able to provide further information into those MDTs. That is often a conversation between the GP and the consultant. That what I was going to link that into is where, you know, the shared care record could also be vital in that, in reducing the kind of the discrepancy between knowledge at secondary and primary care. So I think it's just how do we learn from the things that have gone well, and how do we push that into other places, and can we try and reduce the bureaucracy between primary and secondary care?
Okay. I'm going to take Adam.
Yeah, as speaking as a pharmacist, the worst medicine to dispense are the ones that either aren't necessary or are doing harm, and I think this paper talks to that. I think it's a good paper. It sets out the challenge, and it's really important work to do, especially when you view it as you have through the falls and frailty lens, as the patient mentions. For those reading the paper, it does mention a financial element, but I think the primary purpose is the patient's safety and the medicine's optimization with a financial side effect, which is positive. Saying that, there is a couple of pieces missing. I won't repeat what Naomi said, because there's a couple of that secondary primary care interface, which is huge. But there's some really good work in our system we need to capture. There was a brilliant piece of work in Warrington, producing some deprescribing guidance that isn't in there at the moment. And there's some stuff that the feeling I get from it at the moment is it's a bit like a meds management silo, and it needs to be broader. We're an integrated care system. How do we get everyone involved rather than just the prescriber adjacent teams? So, you know, and that goes to actually performing the work, whether they're identifying the cohorts, whether they're onboarding people onto that process and giving them reassurance about why they're starting off on a medicine review process. That'll be really good. I was really pleased to see the enablers. They'll be key, and they start to mention the right things. And I think that echoes my view of it can't just be a hub service. And I think actually involving that whole end-to-end element of the integrated care that we have, I think will be key to it. Thank you.
Totally support the work to address polypharmacy. It's a well-established patient safety risk, and can improve outcomes by actually taking people off many medications that have been on for a long time and perhaps not needed. So fully support that. Just a couple of programme questions really. There is a comment in finance that it will support delivery of 2.4 million savings. What it doesn't say is how much does the programme cost, because I see that it's actually establishing new posts. So it would be really helpful to have a sense of how much are we investing to deliver 2.4 million savings, and it was unclear to me. And in this year, the appendix very clearly states that the 3 aims of reducing items, falls and anticholinergic drugs. Again, as a programme that we're supporting and investing in, it'd be helpful to have some quantification of what we're going to deliver this year. What does the 2.4 million relate to? So how will we know we've done well on this programme? It's hugely important to address it. Thank you.
Thank you. Any further questions? Hilary?
Fully support this. I think it's a great programme. I think there's a great benefit in developing patient champions as agents of change within this as well. And some of the best examples I've seen of that working nationally is where you get great patients advocating in the mental health space and also using the voluntary sector for that. And the other point I wanted to make was the impact of social prescribing and are we really maximising the people who can truly realise the benefits of social prescribing. And also just wanted to mention the inclusion of non-medical prescribers as well. So this isn't just a pure medical model of clinical intervention. There's people out there who are practicing in the non-medical prescribing space as well. So to make sure they're included in the communities of practice.
Thank you, Hilary. Before you sum up, just 2 comments from me. Firstly, around the Polypharmacy steering group. What we've heard today, it's a point I wanted to make, also is about the engagement of patients in that, and they should be in the leadership group so that we can incorporate patients' voice very, very strongly in that. And the second point is about the learning system. It's not just about polypharmacy, but we know we can do better about spreading good practice through each of our local authority areas, or however we want to define place, especially into the future. And perhaps you could give some thought to understanding through the governance structure, how do we have, I was going to say people, but resource dedicated to learning, spreading the learning.
Thank you, Chair. Thank you for the questions and comments, colleagues. It's much appreciated. Certainly the primary-secondary care interface is a vital part of what we do and will be significantly lent on to deliver improvements. It isn't right that it takes a fortnight for details to get out to our GPs. The Sefton Hub, this comes down to the idea of strategic commissioning, does it not? You know, what is the right service to deploy out there that's the most effective use of our money? And overall, in terms of the investment compared to the savings, and that's before we get to the improved patient outcomes, which we've already touched on, it's around a 2.5 to 3 to 1 return on that investment from what we can see. We're looking at around £1 million extra investment to deliver that additional saving. So for me, it's one of those, and we're looking to work closely with our pharmacy colleagues to find the way that we manoeuvre through this in well understood challenging financial times, that we do find a route to put the investment that drives out real improvements for our patients and ideally the savings into the system as well. And we work very hard and very carefully to do that. As a core pillar of data into action, we absolutely will be capturing the evidence of impact of doing this work, and therefore continuing to build the case that this is commissioned in that strategic sense across the system long term. And I welcome the idea that we are broader in this. As I alluded to, with citizens' advice on prescription, it makes an active difference when we better work with our social prescribing as well. It's great to know that not everything needs a pill.
Thanks, Rowan. So, Board's asked to note the current position, endorse the ICB Polypharmacy programme and approach, and note the further reporting via the Quality and Performance Committee. And if I could put an additional ask on the reporting, give me a... I'd like to see this back at Board in terms of some of the impact, including your realisation of the investment, returns on investment, as well as the patient experience and outcome measures. Give me a view when that should come back.
Should we say 6 to 9 months, Chair?
Okay, so let's say 9 months then. Thank you. And I think along with Dr. Irving and Dr. Jones here. No, I can't see him. Dr. Irving, you're on the next agenda item.
Yeah, thank you. As Greg steps forward, delighted that he's sharing with us a report that board requested that we would bring back some update of the work of the integrated research and innovation system that we've created here, something that we are justly proud of and hence grateful that Greg is reporting to board this morning. Thank you.
Thank you, Rowan. Thank you, Chair. So we last reported to board back in January 24, where we established the integrated research and innovation system, meeting the statutory obligation for supporting research and innovation. We've fulfilled the plans around and followed the guidance around maximising the benefits of research, principally acting as the central convener for the wider health and research ecosystem. We'd like to give an overview of the update on progress and present some proposed priorities that are very much aligned to the delivery plan and the 3 shifts that have been mentioned earlier today, principally focusing on population health and neighbourhoods. So some high-level bits from the report. I think we've firmly established IRIS as a national leader in research and innovation. Of particular strength has been our work in primary care and the community around research and innovation. For example, out of our 349 practices, half are engaged in research, 131 very actively recruiting, and 53 actually delivering commercial research activity as well. Put that into a national context, we do 15% compared with 6% nationally. We're now in the top 3 for primary care recruitment nationally. We're the top ICB in terms of recruitment in deprived communities, going beyond our levels of deprivation. And I think that's a real testament to our deep end network of practices and our inclusive approach to research. I think that's really important. We're in the top 3 for commercial research activity as well, just outside London and Oxford, so really performing quite well on that front. And in terms of number of studies open, we're top of the tree from that perspective as well, so indicating that Cheshire and Mersey is a really good place to come and do research. We've managed to attract considerable infrastructure investment. Some highlights from that: 1.2 and a 4.2 capital infrastructure fund. That's funded facilities to strengthen the primary care research network. So there's a network of hubs, mobile units, and the principal thought behind that is to bring research closer to the community. We've had multiple tranches of research engagement network funding, which is looking at engagement with different aspects of the community, voluntary sector, and as I said, we've had several tranches of that, and there's a report if people would like to look at that in detail. We've had a very nationally competitive funding for a £5.7 million, a system-wide funding for commercial research delivery centres as well. That, as I say, they were very competitive, so it's really good that that's actually come to the region. So, Chair, we would like to build on some of that and expand that work, particularly aligned to the delivery plan and the shifts that are in place by really strengthening research that moves towards neighbourhoods and population health, strengthening that research in primary care, public health and social care as well. That's not to say that we're not going to continue to support the excellent life science research and research that takes place in secondary care as well, as we've seen from the CRDC awards that we're doing particularly well from that perspective. The rationale, some key points in relation to why that shift. A third of our population live in the 20% most deprived neighbourhoods, and it's really important that we engage them in research activity. In terms of healthy life years expectancy, the region is about 6 years below the national average, and there's a significant burden of chronic disease. As I said, I think research innovation really should happen where patients live, and we can support recruitment and enable them to be part of research as well. There's been a lot of stakeholder involvement in what we've proposed, members of the public and the wider ecosystem. I won't go through them all, but I have listed some key enablers that I think are worthy of note in the pack. I've mentioned about the Research Engagement Network. CHIL, the Civic Health Innovation Laboratories, has had funding of over 10 million from the Office of Life Science around mental health research. A big programme that the ICB supports, the NHR Applied Research Collaboration, that had £14 million worth of funding, and crucially it attracted 48 million of external investment into the local health economy. The ARC has a very strong thread of health inequalities, and it's in the process of submitting for a further tranche of funding that's going to support some of the activities that mentioned today, evaluation and other work as well. Our universities, we've got a really strong system of HEIs, notably 2 new medical schools on the patch as well. We've got really strong links with the NIHR infrastructure and the NIHR academies, and we're really attracting some significant investment into the system. Something I'm really pleased to report as well is that we've got really strong place-based collaborations as well. Wirral Research Collaborative, Halton Research Alliance, St Helens Research and Innovation Academy, strong network in Liverpool as well, and that's been very much enabled by IRIS. We've got an eye on the future with machine learning, and we've worked very closely with UKRI and Hartree. And from an innovation perspective, Health Innovation North West Coast have been a really key partner, and we've also seen investment from the City region as well, such as a £4 million worth of investment at Alderhay, looking at setting up an innovation zone. In terms of funding, there's no ask for additional funding here, and I've highlighted some of the headlines in terms of some of the funding that's been brought in. Just to highlight the NIHR report that for every £1 that's been invested in funding, it's thought to bring £13 back into the local wider economy, Chair. Thank you.
Thank you, Greg, and it's so pleasing to hear the progress that's been made in the last 12 months or so, so thank you very much for that. Paul, is there anything you wanted to add as chair of the committee?
Thanks, Chair. Well, only to say that throughout the morning I've heard the word innovation, learning constantly referred to. You spoke about it in terms of what do we know about food banks and gluten. Can we learn from other services in terms of long COVID? How can we measure the impact of polypharmacy? And the point Claire made earlier about mainstream evaluations not being effective and on time. That's exactly what we want to do and promote to give you evidence for innovation as we move forward. Thank you, Chair.
Thank you, Paul. Louise?
Thank you. I mean, really, really good to see this paper. It really sets out what impressive assets we've got on this patch, and it sets it out very comprehensively. I think it's timely to do this. What we suspect around what's coming down from the 10-year plan, but what we know is coming down from the life sector plan, means that as a system, if we can articulate really clearly how those assets work together, are aligned around a single set of objectives as you're suggesting, that's going to put us in a really strong position for those competitive processes that we know will be put in place. And really just a strong message of support from me to have that R&I piece maintained from an ICB level to hold the ring and keep this local and relevant. So excellent paper. Thank you very much.
Thanks, Louise. That's most certainly our ambition to keep this local. We're in negotiation. Rowan, were there any final comments you wanted to make?
I guess, Chair, only to say, as an active academic in our system, I'm proud of what we're doing. It's right. Good quality research improves patient outcomes. We are in a new world coming with Model ICB, and I'm hoping to work with adjoining ICBs that we make sure that we preserve the progress we've made on offering good quality research to those that we serve in the future, and there might be new models of going ahead to do that. And I'm grateful that all of our patients, wherever possible, are given those opportunities to benefit from high quality research. Thank you, Chair.
Thanks, Ron. So it's here to recognise the work that's been going on. Thank you again, Greg, and to support the priorities. People comfortable with that? Thank you. Mike. Oh, welcome, Katie.
Okay, I didn't know you were there. Good. Right, brilliant. Okay, so we'll be very brief, but this is in your pack. You've got an overview of the staff survey and the system, and you've also got an overview of what's happening within the ICB. The thing about the staff survey is it's quite clunky in a way, because it covers a period from September and November last year, and it gets published and we act upon it now. And there is a plan, there is a thought, and it's been there before, to try and make this every 2 years, so we've actually got a much longer period to actually implement and do the plans. The system stuff is all of it's pretty steady state. Just to note that where there are issues in particular organisations in the system, so NHS North West's lead that work, and I support them to go in and we look at how we can help. Within our organisation, there's not been massive statistical variation. In fact, what you could say is that we know we're into and going into an even bigger period of change, but we kind of go in a reasonable position, is what I'd say. And I was hoping you'd just pick out a few highlights. Is that okay, Katie?
Thanks, Mike. Thanks, Chair. So as Mike said, we got the summary of the ICB and the ICS in this paper. Just for the ICB, we had a response rate of 73%. It was slightly down on last year, which was 77%. It's still a really good percentage rate, higher than our other ICBs. And as an ICB, we are normally higher than kind of our trusts, who normally get about 50%. Just in terms of the engagement score and morale score, we are slightly down on last year's, but as Mike said, none of our scores are statistically significantly down. But again, we are above average on all of our kind of peer groups on engagement, morale, and all of our people promise themes as well. I suppose looking at our North West ICBs in comparison, only Greater Manchester took part this year. Langston South Cumbria ICB made the decision not to take part in the staff survey this year, but we are higher as a response rate than Greater Manchester. And as you'll see in your pack, we have compared ourselves across the kind of 3 years that the ICB has been in existence on the people promise themes. And we have stayed relatively stable across all of the 3 years. And I think, as Mike said, the timings of them, as an ICB, we've not been in a great shape. The times of the staff survey, the first year we had management of change, last year we had Mars. And obviously when we go into this year's, we would have kind of it's still being kind of like consultation kind of phase. So the timings of when we're asking staff how they're feeling, would you recommend this organisation as a place to work, haven't really been great. So actually I suppose it's quite positive that we've not deteriorated. We have kind of stayed quite stable. And again, as I said, we are above our peer groups. We are quite good score on compassionate and inclusive, so our staff did say that they felt we are a compassionate inclusive organisation, and we do have compassionate and inclusive leadership, which is really positive. And as Mike said, it kind of says where we are at this stage and how staff feel as we are going into kind of the workforce cut, so it kind of gives us a baseline of what our staff are feeling currently. So although it is positive, we haven't deteriorated. We know that some of the scores aren't where we would like to be in terms of kind of we are recognised and rewarded, we are safe and healthy. They are 6.65 and 6.4. We're kind of, that isn't where we would like to be as an ICB. We would like to see higher scores. And specifically, we are always learning. We are 5.13 out of 10. So again, it's not somewhere we would like to be on that, and we have got plans to do some work on kind of our L&D offer as well. We've also analysed the 199 free text comments that we got from staff, and they were around recruitment freezes, transparent communications, mental health and wellbeing support, which kind of supported kind of the rest of the survey. So what we have done from the results which we got in January was we have held one-to-one meetings with all of our execs. We asked our staff engagement reps and our people operations group to attend those as well. And then we've held 4 open staff engagement sessions. We slightly redesigned the sessions just as we were going to hold these. Obviously the announcement of the workforce cuts came in. So we slightly changed them to feedback on the staff survey, but actually using the people promise themes as the framework of the discussions, because they are really good framework of kind of staff engagement. We asked staff what they would like as immediate support going through these workforce cuts, and then kind of more medium and long term support that they would need. So what staff were saying then kind of broadly did fit into what the staff survey results were saying. So they would like more health and wellbeing offers, and we were actually really pleased to say that actually in the last month and two we've significantly increased our health and wellbeing offer to staff. We've got health checks now for all staff. We've set managers support circles up. We've got My Money Matters in place. We've set a few more informal sessions up, so brew buddies, self-compassion, self-care sessions, which have been really, really well attended by our staff and really, really positively fed back, which is really positive. Some of the other feedback we've had are around transparent comms, which again we've had really positive feedback since we've kind of launched the bi-weekly We Are Ones and kind of the FAQ. So we've had really positive feedback around that. And the other feedback is the opportunity to connect and have more face-to-face working in the office, more face-to-face engagement sessions, which again we are going to be putting on roadshows over the next few months as well. And some of the other feedback, which again linked to the feedback we had last year, was just those simple thank yous from staff and their managers, and kind of how to be rewarded and recognised, and a bit more of a promotion of some of the schemes that we already have in place, like our employee of the quarter and our team of the quarter. And again, like I've said, there was a lot of feedback through the survey and the subsequent staff engagement sessions around our learning and development offer. There has been feedback on the quality of our appraisals and kind of what happens after the appraisals. So it's something we will be looking at probably in the next 3 to 4 months in terms of what is our L&D offer, and just really promoting what our L&D offer is. I think people seem to think it's a bit more of the traditional kind of old CCG offer where there's a firm budget and each team get a budget, whereas we actually do have a lot of subscriptions to different L&D offers. So we just need to kind of do a bit more promotion and communications on that. And long service award continually crops up. People are really keen to kind of launch our long service award, which we were hoping to do in the next few months. So that was our ICB. Just in terms of the ICS, we had an increased response rate across all of our providers, so it's gone up to 50.83%. We scored above national average in 3 of our people promise themes. So we are safe and healthy, we are compassionate and inclusive, and we have a voice that counts. And we had a real positive shift across the system in terms of reporting of bullying and harassment went down, staff appraisals went up. Again, it's probably not where we would like to be as a system, but it's kind of moving in the right direction. And really positive to hear that staff reported a better commitment to work-life balance and flexible working. There were slight declines in time pressure concerns and career development perceptions. So just in terms of our next step for the system, we have a quarterly ICS staff retention forum where all of our systems come together to talk about anything to kind of do with staff experience, engagement and retention. So we will be, us and NHS England will be presenting the ICS feedback back in June, and that's where we'll kind of discuss how can we work together to learn lessons, share best practice, and we'll come up with kind of some system-wide prioritisation in terms of how we can all work together. And as Mike said, some of the trusts that we did see a slight deterioration, we'll be doing kind of individual work with those trusts as well. And just to note as well, we did have over the past 3 years People Promise Exemplar sites. So 8 of our trusts have gone through that People Promise Exemplar sites, and we have seen some positive increases in those trust staff survey results when they had one dedicated resource to look at the People Promise. That was externally funded by NHS England, and the funding has come to an end now, but we'll be working with all of our trusts to kind of share lessons and see without funding what we can do in terms of kind of improving kind of staff experience and thinking about this next staff survey, how we can work on that. I think that was it for me, Chair. Thank you.
Thank you, Katie. Any questions or comments? Naomi?
think everybody knows what I'm going to say. There's no primary care. We've got no understanding of the staff morale, of the staff engagement across all 4 contractor groups. And I know I say it every year, but I don't think it's that hard to send an email out. I understand it's very difficult to then collate and evaluate that information, but this is not reflective of the whole of the ICS, because there is a significant number of staff who are not being included here.
Absolutely agree. It's a process that's run nationally, and it's not just GPs that were included. I've got an integrated team with a number of people from NHSE who weren't included in because they're not big enough. They don't get part of the survey. So it's just one of those issues that's ongoing that we're trying to influence, really, because it does mean you have teams where you have the morale of half of it and not the other half. All right?
Yeah. So can I just add? Oh, sorry, Chair.
We have talked about it for 3 years in the board. Mike, through you, will you work through a specification, understand how much that's going to cost us, and let's make a decision on this through the executive committee? Yeah. Yep, is that okay? I'm going to go to Katie and Claire and then Paul.
Thank you. It was just to add, I have actually had conversations with the primary care training hub around what we can do together on this. There was the GP staff survey. It wasn't primary care, it was all of the GP staff survey. For the results that we got back, it wasn't particularly helpful. It was a Department of Health and NHS England led initiative, and we weren't able to break the Cheshire and Merseyside results down into place, so it wasn't particularly that helpful. But I have had conversations around how we can actually do our own. And like I said, it's not that hard to kind of replicate the questions, just put it into something like Microsoft Forms. Mike's gone off. We are in conversations to kind of how we can do something like that, yeah.
Thanks, Katie. That's potentially a way forward. Thank you. Claire?
It was a similar point. We took a decision with the LMCs and with the GP practices last year not to complete it. And I think we are doing it this year, but I think, as you said, it's not particularly meaningful. We will look at it across all 4 contractor groups, but there will be a job of work, and it's not just from the ICB to do the work, it's about the practices and the contractor groups engaging with their staff. And there was an issue about, sending questionnaires out to staff and their home addresses and various things. We'll work through it, but we did take a decision last year collectively with practices and LMCs not to go ahead. So I think it's not just, we need to look at this together, I think, going forward. Thank you.
Okay, let's do that. Let's look forward. Paul?
Just an offer. With the infrastructure we have, which we've spoken about in terms of research and innovation, we could support this and help to generate some form of independent evaluation if required.
I forgot to say at the beginning of the meeting that we can only have 2 microphones on, I think. So as soon as somebody presses a button, everything else goes off. So, well, great offer, Paul. Great prompt. Katie, well presented, thank you. And let's make something happen for primary care in its general sense. Thank you. And we've seen the overall results there for both the ICB and the ICS system. Steady state, I guess, is what we're seeing. People happy to move on? Yeah, thank you. I'm going to go to the minutes, the meeting. Any matters of accuracy? People happy to accept the minutes? It's been true and accurate. Yep, thank you. Board action log. I'm going to say the comment I've said a few times. It is not complete. It is not appropriate, satisfactory to send that board action log back to the board in the way it is. So I'm going to ask, through Matthew, I'm going to ask for that to be completed appropriately and updated. I don't really want to say that again. So thank you. Closing remarks of the meeting. There's been some challenging conversations today, some really heart of the matter in terms of taking difficult decisions. We're starting to formulate a way forward, but it's really, really important that we hear the voice of service users, patients and the public in what we do. So thank you for the meeting. I'm going to say that we reconvene for part 2 in 30 minutes. So by my watch, that's 1:10. Thank you.